Hi guys, welcome to the topic of rheumatology where the immune system turns against self and the security system which is supposed to protect us is actually turning against the own body cells. I would like to begin by describing Selena Gomez case. Selena Gomez is a famous pop singer from America. I'm very sure you would have listened to her song Calm Down, which was like a rage on internet about 1 to 2 years ago. Now in Selena Gomez case, she lives in America, which is supposed to have the most advanced medical systems, but her SLE diagnosis was missed to a point that she went into renal failure. Yes, guys, she developed lupus nephritis. She went into end stage renal disease and she had to undergo a kidney transplantation. So this is a screenshot of from the X profile. X is like formerly Twitter. This is from the X profile of Selena Gomez, where she posted a picture of herself, and after she underwent the kidney transplantation, her friend had donated the kidney for her. And why I chose to describe it is because mostly you will notice that celebrities try to hide their illness. But kudos to her, she openly came out saying that women need to be more proactive about their health. And like I was diagnosed with SLE, and then subsequent to that, like she was put on anti-rejection drugs, that is like steroids, etc. So she put on a lot of weight also. So on social media, like people were body shaming her because they were not aware of her medical status. But then she described how the body goes through stages when a person suffers from a serious medical illness. So what I want to say at this moment is that lupus nephritis is one of the biggest killers for patients of SLE. In fact, there's a question in your exam also saying that what is the number one cause of death in patients of SLE after 10 years of diagnosis. Like suppose patient was diagnosed at 30 and now patient is 45 years of age. At 45, the cause of death, I'll be writing it down subsequently, listen to me. After like 45 years of age, the cause of death is accelerated atherosclerosis, that is heart disease. But in the first 10 years of diagnosis, like suppose patient is diagnosed at like 35 years of age and like the disease process started around about 30, and there was a long intervening period in which the diagnosis was not made. So in the first decade of life within the diagnosis, I'm saying first decade from the perspective of diagnosis, then the death would be lupus nephritis. So I'm going to begin by describing this very characteristic kidney light microscopy finding that you would have read even in pathology, where you can notice the peculiar appearance of the renal capillaries that look like wire loops. So one of the histopathological findings that they love to incorporate, though I'll be teaching you the treatment part of lupus nephritis also at the moment, just a recap into pathology, we get wire loop lesions. Then in the same question, they can also add the finding of immunofluorescence. You can see IgM, IgG, IgA, C3. I mean, everybody is like joining the party. Every part of the immune system is saying, let me have a piece of the, dish that is the person's life is being taken away by antibodies which are attacking self. Everybody is attacking the glomerulus. So since everybody has joined the party, that is why we call it a full house effect. Full house would be like you are having a party and like everybody is joined in. Today, like this unfortunate party is being joined by antibodies which are causing immune complexes, and because SLE is an example of type 3 hypersensitivity reaction. They love to ask about light microscopy, immunofluorescence, and electron microscopy findings. So with respect to the electron microscopy findings, I want to highlight that this would be the only condition, lupus nephritis, where you will read about subendothelial deposits. In all other like diseases of the kidney that you read, and I've described it separately in the kidney section also, you always read about subepithelial deposits. But because like SLE is a disease where antibodies are turning against self blood vessels. So because blood vessels are getting affected, that is why I said the word endothelial cells. So at the moment in the opening part of this particular discussion, what I've tried to explain is one of the reasons why these patients of SLE can die. I'll say once again, within the first 10 years of diagnosis, if death occurs, then it's due to kidney disease. And if the death occurs after 10 years, like suppose patient was diagnosed at 30 and death occurs at 45, 50, whatever, then usually the cause of death would be accelerated atherosclerosis, that is the enhanced cardiovascular mortality. Now, this disease is an example of type 3 hypersensitivity reaction. And in the same, option, he will also ask you with respect to the complement status. So this is seen in patients who are having deficiency of C1q. I would like to draw a parallel here. The parallel is just like you're aware that C5 to C9 deficiency, that is membrane attack complex deficiency, contributes to recurrent meningococcal meningitis episodes. I've described that in the CNS part. I'm just saying it verbally here. Deficiency of C5 to C9, that is the membrane attack complex deficiency, contributes to increased incidence of recurrent episodes of meningococcal meningitis. In a similar spirit, C1q deficiency increases the risk of person developing having systemic lupus erythematosus. A must-have criteria for diagnosis of this condition is anti-nuclear antibody. So I'll be describing the various staining patterns that you see, like a homogeneous pattern, nucleolar pattern, centromere pattern, which would be a revision of your pathology as well. Now, as far as the most common body system that is involved in this condition, if they say what is the overall most common body system involved, and skin is also given and musculoskeletal system is also given, then overall the most common body system involved in this condition should be answered as musculoskeletal. Here I want to point out that when this question came in the INICET exam, a lot of guys casually answered it as skin, because traditionally we read about like butterfly rash, malar rash. I'll show you the image of that also, because we are like focused on the word butterfly rash and like malar rash. So therefore, like the tendency of most students is to answer it as the dermatological involvement is most common, but that is not the case. In fact, most of these patients will come to you with development of joint pain. And when I say joint pain, the thought process of a lot of students is that, sir, are you talking about rheumatoid arthritis? No, in rheumatoid arthritis, it's like the small joints of the hand that are getting involved. Here it would be like the large joints, like the knee joint or the ankle joint. So we would be having a symmetrical but a non-erosive arthritis. It's a non-erosive. See, rheumatoid arthritis is like erosive, right? In rheumatoid arthritis, we read about swan neck deformity, Bouton's deformity. I'll show you images for the same also. Very interesting data. But at the moment, this would be musculoskeletal system involvement, which will contribute to low-grade fever. Along with that, there would be myalgia and there would be joint pain that would be present. In fact, I could write it here because a lot of these patients and a lot of these questions begin with low-grade fever. So even tuberculosis will come in our mind. The fever could be persisting for 3 weeks or maybe even more. Patient takes paracetamol, fever comes down, and when the effect of medicine goes away, fever comes back. So similarly like in TB, along with that, there's a myalgia which is encountered, the ESR is elevated. So like the acute phase reactants in the body of this patient will begin to rise, and there are part of diagnostic criteria also. And then he will also talk about joint pain which is present in these patients with respect to like the knee joint or the ankle joint, like the weight bearing joints of the body would be predominantly affected. So musculoskeletal system involvement is one of the commonest ones that we see. The type of involvement, as I said, is non-erosive, and also patients would be developing anemia. In fact, in her song Calm Down, Selena Gomez has described her like fight with, I would say, depression, psychosis, and pallor and anemia. I mean, when you listen to the lyrics of the song, you can feel that a person is describing his or her illness from the perspective that, like, blood is not getting formed, person is feeling tired, that exhaustion part that would come in. So the most common type of anemia that is seen in this patient would be answered as anemia of chronic disease, understandably, because SLE is a chronic disorder. So anemia of chronic disease would mean that you'll answer this as a normocytic normochromic anemia. Yes, guys. Though you are aware of the fact that anemia of chronic disease can be either normocytic normochromic or microcytic hypochromic, if both are given in the options, then even in hematology, I've said this, that first answer would be normocytic normochromic. But then you cannot take this anemia of chronic disease as a part of the diagnostic criteria in SLE, because anemia of chronic disease can be seen with the inflammatory bowel disease also. So if he says which type of anemia is taken as a diagnostic criteria in SLE, then your answer for systemic lupus erythematosus will be autoimmune hemolytic anemia. Yes, guys, because antibodies are attacking self RBCs, no? So that's why autoimmune hemolytic anemia, which can also be written as Coombs positive hemolytic anemia. The leading cause of death after a decade, as I explained to you, is increased cardiovascular mortality. So in those circumstances, like, patient lived up to 45, 50 years of age or even older, then it is heart disease that would be relatively more common. And one reason for that is that the disease is attacking self blood vessels, so will be attacking coronary arteries also. So the coronary artery inflammation can increase the risk of myocardial infarction in these patients. But if the patient dies in the first decade of of diagnosis, like suppose diagnosis was made at 30 and patient is having illness in the first few years only, then it is mostly lupus nephritis, because patients will not be regular in their treatment. If somebody is like steroids, when you write to somebody, everybody will Google steroids and will literally come and abuse you. Come on, doctor, you're writing steroids, they're having so many side effects, they cause Cushing syndrome. Non-medical people, right? They'll be using like ChatGPT 2.0 paid version. He'll say, I use Claude, I use ChatGPT, I use Perplexity, which is free with my Airtel connection. Everything says Cushing syndrome. Do you know, doctor, what is Cushing syndrome? Do you know how bad it will make me look when I put on weight? Well, I'd say that's a small price to pay, considering that obviously steroids are going to cause side effects, but they're going to prevent the damage that's going to occur to the kidney. But most patients would not listen. So you can have lupus nephritis. Now, at this point, I also want to say from the pharmacology perspective, we have said what drug can be used in all patients of SLE. I mean, like, I can't give steroids. Like, let me give you a contraindication for steroids. Steroids cause psychosis, and SLE also causes psychosis. So, if there are like full blown psychosis occurring in SLE patient, I'll be not comfortable giving steroids to a person. You see, the point is steroids are themselves contributing to psychosis, and SLE is also causing psychosis. So no point. Or let me say, if I say Libman-Sachs endocarditis, there is no role of steroids there. So what I can say is that with respect to SLE, one drug that can be used with respect to all the problems in a patient is hydroxychloroquine. Hydroxychloroquine became very famous at COVID time. Remember when COVID came in 2020, 2021, then like, you'll notice that for prophylaxis, ICMR had advised hydroxychloroquine, and everybody was like, "What? ये तो SLE का दवाई होता है, right? Hydroxychloroquine for prophylaxis of COVID," and it turned out to be like not effective anyway. One more biological molecule which is being used for management of these patients is by the name of belimumab. Now, what this molecule will do is it will cause a depletion of the autoreactive B lymphocytes. See, the B lymphocytes ultimately differentiate into plasma cells, and plasma cells produce antibodies which are attacking self. So, if I will be causing depletion of those autoreactive B lymphocytes, then the lupus nephritis progression will be substantially reduced. So, in the subsequent slides, I'll show you the stages of lupus nephritis, the histopathological names that you have to remember also. But at the moment, I wanted to give you heads up with respect to those kind of questions on the topic of SLE, which are based on facts. These kind of questions cannot be solved by some kind of a logic or by guesswork, because it's a high probability somebody can swap the data of accelerated atherosclerosis and lupus nephritis if somebody has not read it well. But after I've given you information, like I gave example of Selena Gomez, diagnosis was not made, so in the first decade of life, first 10 years, it's gonna be answered as lupus nephritis. But after 10 years, then it would be accelerated atherosclerosis and enhanced cardiovascular mortality. Now I will introduce the concept of DILE, that is drug-induced lupus erythematosus. The reason why DILE, or you will see me use the word DLE, that is discoid lupus erythematosus, and DILE. So DLE is discoid lupus erythematosus, DILE is drug-induced lupus erythematosus. This is asked because one, the gender ratio here is 1:1. You're aware when it comes to SLE, this disease is more common in women as compared to men. The gender ratio is 6:1, but when it comes to drug-induced lupus, it would be 1:1. The renal involvement and the CNS involvement in this condition are rare, and then he can ask you regarding the drugs which are responsible. One of the drugs that is asked is a vasodilator drug. This vasodilator is used for management of hypertension, that is hydralazine. Next is an antitubercular drug by the name of isoniazid. The third one in the hip mnemonic is the one which is the most common cause among the, if he says among the list of drugs that I'm describing before you, he says what is the overall most common cause of drug induced lupus erythematosus, then you will answer this medicine. The last time I've described this molecule is with respect to management of patients of WPW, that is Wolff-Parkinson-White syndrome. So this would be procainamide. And then apart from hip, it is MMQ. For MMQ, it is alpha-methyl-dopa. That's one of another antihypertensive drugs that was earlier used for management of patients of preeclampsia. Then is minocycline. We use this drug usually in patients of acne vulgaris who are not responding to topical antibiotics, and there is nodulocystic acne. So minocycline is one of the very commonly prescribed antibiotics. In contrast to doxycycline, minocycline has a better response with respect to treating patients with nodulocystic acne. And then is another antiarrhythmic drug by the name of quinidine. Both quinidine and procainamide, they belong to the same class of antiarrhythmic drugs. So the mnemonic is HIP and then MMQ. Among these, the single best answer for the number one drug causing drug-induced lupus manifestations is procainamide. Now, obviously, lupus nephritis is always on the top of the mind of the examiner because it's a big time killer. So they can give you a histopathological slide and ask you to identify it. What I have done here is given you two slides simultaneously, one for diabetes and second for lupus. And they're so strikingly different, guys. They're so strikingly different that even if I don't say now, even then, I would say that you just got out of your sleep and I show you this image and say, okay, doctor, tell me. You can see the Bowman space here. You can see a well-preserved Bowman space here, but you can see those, dense nodular deposits which are present in the glomerulus per se. So even if you are like just gotten out of bed and ask you, okay doctor, tell me, is this a slide related to lupus or is it related to diabetes, you'll say, sir, this is for diabetes, right? This is that Kimmelstein-Wilson change that we read. So the slide that I'm showing you at the moment is what is called as nodular glomerulosclerosis. This is not the most common involvement of diabetic nephropathy. It is the most characteristic, mark my words there, most characteristic histopathological finding of diabetic nephropathy. The alternative name for this is Kimmelstein-Wilson change. So I just had to introduce that slide for a comparison basis. And obviously, like when you look at the slide adjacent to that, which I've already introduced before you, when you check out these renal capillaries at multiple areas, the capillary lining looks much more thickened. I'll just zoom it in. The capillary lining looks much more thickened. So that's what is called as a Warlock lesions of lupus nephritis. And therefore, he can now ask you regarding the various classes and the treatments that we'll be doing. At this point, I also want to bring to your attention that this lupus nephritis that I've currently described, with respect to class 6, which is going to be right at the bottom of the table, almost like 90% of the glomeruli are gone. So there is no point of giving steroids in a burnt out kidney. If I have to give steroids, I have to give it before the damage becomes to that particular stage where a person goes into end stage renal disease. I mean, if that, like, I'll use the English phrase, burnt out kidney. I mean, if, the fire has burnt the entire thing, then what is the point of giving steroids? It is to be given before the fire has caused. I mean, you need to control the fire, right? You are like the fireman controlling the fire. No point of giving it if somebody has gone into glomerulosclerosis. So steroids would be used prior to this. So one of the earliest, he can say, what is the earliest histopathological finding? And your answer would be minimal. Yes, guys, just like you are comfortable with minimal chain disease, you need to be comfortable with minimal mesangial glomerulonephritis, MMG, minimal mesangial glomerulonephritis. This would be with mesangial deposits visible on electron microscopy. Then we upgrade to mesangial-proliferative lupus nephritis. Then comes the word focal, right? Earlier I was saying the word nodular glomerulosclerosis. Now it is focal proliferative nephritis. And this is class 3 where you have to go all out ballistic. I mean, this is where steroids have to be used. When it comes to class 1, I might be using hydroxychloroquine and like that would be all. For 2, I can say because hypertension would start coming. So I'll start using ACE inhibitors in a patient. And along with that, I'll start giving steroids. Steroids are to be given in 2, 3, and 4. In fact, from the MCQ perspective, if he says which of these is the most common stage, and even if he says which of these is most severe, yes, guys, even if he says the word which among these is the most severe, because from the perspective of like most severe from the perspective of prescribing steroids, right? Obviously, like if I go by English, then stage 6, class 6 is looking to be like most severe. But what I want to say is from the perspective of treatment, like I need to intervene at this point of time. So most severe from the perspective of treatment, where treatment has to be started. Otherwise, I get a burnt out kidney, or the most common variety that is asked is the one that is class 4, for which you will say the word diffuse proliferative nephritis. Yes, guys, you need to get used to the names here. At this moment, I want to give a parallel example. Just like in diabetic nephropathy, the most common histopathological finding is diffuse glomerulosclerosis, right? Here I'm using the word diffuse proliferative. The word is diffuse proliferative nephritis, lupus nephritis. I mean, that is the situation when I'll be going all out aggressive. I'll be using steroids in this patient. And if I don't, then a patient goes into class 5 where you will get nephrotic syndrome manifestations. Then you will get secondary nephrotic syndrome. One of the leading causes of secondary nephrotic syndrome is diabetes, but the second important cause after diabetes is lupus nephritis only. And then after all, anyway, like there is a glomerulosclerosis that is occurring in a patient. So these are like the stages that need to be remembered. The most important question to be remembered is the most severe one, and overall the most common one is class 4 of lupus nephritis. Now, before we start with the clinical domain, a bit of like heads up with respect to the anti-nuclear antibody patterns that I'll be showing you. So we finished the theory part here. In SLE, the pattern that we get would be answered by you as homogeneous. Along with that, speckled pattern can also be there, but the homogeneous pattern is what we see for double-stranded DNA or anti-Smith antibody, which is a specific antibody for diagnosis. In contrast, when it comes to systemic sclerosis, that will be discussed subsequently, also called as scleroderma, the ANA positivity will be having a nucleolar pattern. And then I'll describe CREST syndrome to you, where the 5 manifestations will be there. I'll not get into the full forms at the moment, but here, like, you need to remember the word centromere antibodies. anti-centromere antibodies, and the pattern which is present here is called as centromere pattern. Now, how they look like, that will also be shown to you and will be discussed. But then first and foremost, we need to get used to the vocabulary. Homogeneous for SLE, that would be antibody against double-stranded DNA, anti-Smith antibody, and the two separate colors are because there's a separate topic that will be handled. But why is it being covered right now is because a lot of questions of systemic sclerosis will begin by saying what is the initial screening test that would be done for a patient with systemic sclerosis. It's still anti-nuclear antibody. Guys, anti-nuclear antibodies are entry-level criteria, must-have criteria for diagnosis of SLE. That is okay, but ANA positivity, nucleolar, or like the centromere pattern can also be seen in SLE as well as CREST syndrome. So just by reading the word ANA, don't assume that the question is on SLE. You need to look at the clinical features also, and the clinical features that I'll describe before you for the disorders that are mentioned in blue will come up subsequently. But I would like to give you heads up: Raynaud's phenomenon. If you get Raynaud's phenomenon written in a question, or you get the word written like a patient is having extreme severe pulmonary fibrosis and pulmonary artery hypertension, then think in terms of systemic sclerosis. Will become more clear to you as I progress in the disorder. Obviously, antibodies will assist you, but like the clinical domain is to be used for evaluating these questions. And now we'll focus on the clinical manifestations that we'll be saying. So I will begin with the mnemonic, very cliche, very simple and straightforward, that is called as MD-SOSP brain, a very old cliche mnemonic that helps us remember the manifestations of the disorder. The first and the foremost is the word Malheur rash. And what he did in the MCQ was, I think this was FMG exam couple of years ago, he deliberately wrote the word Malheur flush. And students were like, I think it is okay. It is Malheur rash and Malheur flush is the same. And I was like, no, man, they're not the same. Malheur flush is something that I'm going to be seeing with respect to mitral stenosis. Yes, guys, that's like, I would say a flush of the cheeks that is seen in patients of MS, mitral stenosis, and is not a feature of systemic lupus erythematosus. What I get here is that classical Malheur rash, also called as a butterfly rash. And this rash will be having that classical sparing of the nasolabial folds. So let me write down the data here. This will be written in the books also. The feature in SLE, that is the skin feature, is Malheur rash. Also, it is called as butterfly rash, and the characteristic thing is it would be causing sparing of the nasolabial folds. While reading the question fast, there is a distinct possibility. Like in FMG exam, what they've started doing is they started giving those 4-liner, 5-liner questions. They are very easy questions. Believe me, they're like just a Lay's, that chips packet is there. No, it's full of air, hardly any chips. Similarly, those FMG exam questions, guys, people got like, they got afraid of the volume of the question. But it was like that that super inflated packet of chips, no, where andar kuch nahi hai, mal kuch nahi hai. It's like those few words that have to be picked up. So my humble request to you guys is that don't get bogged down by the length of the question. Bigger the question, more of the chances of scoring it. Clinical question hota na, you have a higher chances of scoring it, guys, as compared to that one-liner. One-liner is more difficult in my opinion because either you know it or you don't know it, right? You can't bluff around there. But the clinical information, because of overlapping clinical features, you can still figure out the diagnosis if you listen to me carefully for another 2+ hours. So Malheur rash with sparing of the nasolabial folds is one of the features that is seen here, and this is also referred to as butterfly rash. It can be involving the sun-exposed parts of the body. So even the earlobes of the patient and dorsum of the hand can be involved. The second feature that you get in MD is the discoid rash, where you get thick scales and follicular plugs present. And along with this, what you will also have is the sebaceous glands, like in our skin. No, you can see the pores on the skin. Like if you check out my skin closely in a mirror, you can see pores. Those pores are where the sebaceous glands and the sweat glands would be opening. So in this particular disorder, what will happen is that the autoimmunity will destroy sebaceous glands and sweat glands. At the end of the day, in you and me, like there's like oil on the forehead, oil on the nose. Like some of us have oily skin, some have less oily skin. But what I want to say is that sweat glands and sebaceous glands would be destroyed, and there would be thick scales and follicular plugs also seen. That's with respect to discoid rash that can be seen, written as discoid lupus erythematosus. And then we get an important manifestation called as serositis. Now, serositis would mean a 2x2 table where we discuss the most common and the least common lung and the heart manifestation. 4 questions covered here simultaneously. The commonest lung involvement in patients of SLE is pleuritis, and this would be associated with a pleural friction rub. And when it comes to the heart involvement, it would be pericarditis, where there would be a pericardial friction rub. And if a doctor is in doubt, then you can do ECG. ECG will be showing a ST segment change in pericarditis. but there would be no ST segment changes with respect to pleuritis, and yes, both can coexist also. Now let us focus on the least common feature with respect to the lungs. The least common manifestation is itself a question: shrinking lung syndrome. Because I'm saying the word shrinking lung syndrome, therefore in these patients, like breathing difficulty or exercise intolerance can be appreciated. That's because the lung capacity will be relatively reduced. In contrast, when he says the word least common, cardiac manifestation in patients of SLE, when I'll write the name, I am like 200% sure that all of you have read this upteenth number of times, that the manifestation that is seen here would be that of sterile vegetations. These sterile vegetations would be composed up of fibrin, and they'll be involving the heart valves. The manifestation is called as Libman-Sachs endocarditis. Contrast this with a discussion that we had for infective endocarditis, where we get vegetations on the surface of the heart valves which are filled with bacteria. Here, what I'm drawing is, let me say this is the representation of the mitral valve. I am showing sterile vegetations. These sterile vegetations that are found in Libman-Sachs are found on the undersurface of the heart valve. Yes, guys, unlike in infective endocarditis, where any surface of the heart valve can be involved. It can be superior surface, inferior surface. In Libman-Sachs endocarditis, it is predominantly the undersurface of the valves that would be involved. And he can also ask you for these sterile vegetations, what is the commonest valve that is involved and what is the commonest valvular lesion that can be seen. So what I want to say is, by default, anytime heart is involved, if he says what is the most common cardiac like valvular lesion associated, you by default can answer mitral regurgitation. Yes, guys, I'll give examples also. Where answer is not mitral regurgitation, I'll tell you, but at the moment I want to say that suppose I ask you, okay, doctor, tell me what is the commonest valvular lesion in a patient of infective endocarditis? Or I ask you, okay, tell me what is the commonest valvular lesion that is seen after MI? What is the commonest valvular lesion that is seen in rheumatic heart disease in a child? Rheumatic heart disease in a child. Then your answer is mitral regurgitation. Guys, mitral valve in the human body operates at the highest, I would say, hemodynamic stress. So it's going to be the commonest one getting involved. And even in Libman-Sachs endocarditis, it is like mitral regurgitation that is seen. In all of these conditions that I've seen, if they ask you what is the commonest valvular lesion, then by default the answer is mitral regurgitation. For those of you who are listening maybe first time, you might be a little confused, sir. Rheumatic heart disease also, you said mitral regurgitation. Bache, it is mitral regurgitation because it's a bacha, right? Child. Suppose I was talking about rheumatic heart disease in a patient more than 18 years of age, then it's okay. Mitral stenosis is the most common valvular lesion. That is why in your exam it deliberately asked rheumatic heart disease with a child. What is the commonest valvular lesion that is seen? Your answer would be given as mitral regurgitation. So these are like common, like just by default, I'm saying that mitral valve operates in a body at the highest hemodynamic stress. So it's going to be one of the commonest valvular lesions that are seen. So these are details for serositis. Now I'm going to talk about oral aphthous ulcers and nasopharyngeal ulcers that could be present in these patients. Now, aphthous ulcers are like, I can say, they can occur in normal person also because of stress, because of constipation, due to inflammatory bowel disease. So like multiple times, like maybe I can say once in 5 years, one in 10 years, even you and me can have aphthous ulcer in the inside of the mouth, inside of the cheek for 1 or 2 days. I mean, it will be spicy food will be a problem, then everything is okay. Then you can get it in inflammatory bowel disease. You can get that in Behçet's disease. In the later part of our discussion, I'll speak about Behçet's in detail. It is also called as Silk Road disease. Very interesting disorder. Now, when I described that Silk Road disease, and then is obviously SLE. And at this moment, I want to say that aphthous ulcers are involving oral cavity in all of them. But in Behçet's, I'm just putting a small mark to say. I'll explain that subsequently. So even the notes taking team, please don't note it down at this moment. Right? In Behçet's, the aphthous ulcers can be involving the genitalia, including the vulva and the scrotum. The notes taking team, humbly requested. I know, let it be like in the video. It's okay, right? Because a lot of young doctors are working for like making your life easier and they take out notes. So I need to give them sometimes instructions. It's okay. I mean, we let it be the part of the video. Don't edit it. The message here is Behçet's is very peculiar. The question will talk about genital involvement. I had to speak about it right now because if I hadn't, then the later part, no, when I talk about Behçet's, if the fatigue sets in, people tend to neglect that point. So the importance will come up subsequently. Genitals having aphthous ulcers is a feature that's seen with Behçet's. Obviously, oral cavities involved. More interesting data about Behçet's in a while, called as Silk Route disease. Last time you guys would have read Silk Route disease in geography class, and today I'm teaching you regarding Silk Route. Okay, guys, so we are done with MDSOS now, synovitis. That's a non-erosive arthritis. It's a symmetrical polyarthritis that is seen. We don't have arthritis in these patients. Arthritis would always mean like we don't have erosive arthritis here. Erosive arthritis will always contribute to deformity. So the good news is like you would not have that swan neck and Boutonniere deformity like you get in rheumatoid arthritis. And then we will have photosensitivity. For photosensitivity, I want to say that there is an antibody that is the villain, and the antibody which causes this is called as Rho antibody, Rolane-wala antibody. The person will go out in the sun and the person will end up with first degree burn. I can say like this, if you're making tea or coffee for yourself, Maggie for yourself in the hostel in the night, if your hand accidentally touches the hot plate, you get a first degree burn, which is horribly painful. In this patient, you could be having a first degree burn, not on like, touching something. Obviously that will happen even on standing in the sunlight, like the sun exposed parts of the body, like the face, the neck area, the V of the neck, the hands, dorsum of the hands. Sunlight exposure, something as simple as sunlight exposure can literally cause a first degree burn in these patients. That is photosensitivity. And even here hydroxychloroquine works. Steroids don't work here. Steroids will not work here, but hydroxychloroquine works. For photosensitivity, obviously, I need to use that sunlight protecting lotion, etc. But yep, at the same time, like photosensitivity, hydroxychloroquine will work. Then we get a brain involvement in this patient. So we're done with MDSOSP. I'll say it fast, 15 seconds. Malar rash, discoid rash, serositis, oral aphthous ulcer, synovitis, right? 2 times S, serositis, synovitis, and photosensitivity. And then is the brain involvement, where the standard question is what is the most common CNS involvement? Cognition defects. But don't get tempted by the word lupus cerebritis. Even this is present. Lupus cerebritis is also present. This explains the fact that these patients can be having headaches and even seizures. Yes, guys, that headache and the seizures, headache would be migraine-like headaches. So this lady would be taking like painkillers regularly. Her head keeps on splitting. In fact, in like that Selena Gomez, she like pointed, I used to have headaches and then I used to take Crocin, paracetamol, Tylenol, as they say in America. And my headache never used to go away. I mean, I was listening to her on one of our podcasts, and she said like I used to take Tylenol and I was turning anemic and my urine output was less and like I could not figure out what was happening, breathing troubles coming in. I was going to cardiologist, I was going to have my over specialization, right? I mean, in America, there's over specialization. If the same doctor had been seeing her multiple times, he would have thought, okay, lung involvement, cardiac involvement, then okay, another system getting involved. Here, she was going to a dermatologist and to a kidney specialist and to a cardiologist and to a pulmonologist. So all of them are compartmentalized. Everybody is like doing their, he's saying, I'm restricted to the lung. I don't want to check other organs. Rheumat is a disorder where multiple systems of the body get involved. So you need to like amalgamate all of those to understand what's going wrong with the patient. So yeah, we can be having lupus cerebritis, we can have headache and seizures in these patients also. But overall, the most common like CNS involvement is cognition defects. Then comes obviously the killer that I've already elaborated upon, that is lupus nephritis. I'll just say it quickly. The histopathological findings being wire loop lesions, subendothelial deposits, full house effect, and then stage 4 is like where you have to act and give steroids to the patient, give hydroxychloroquine and belimumab, so that you are able to prevent the further damage and prevent a burnt out kidney. I mean, there's no point of giving steroids with respect to, if the person has gone already into I can say class 6, then there is no point of giving steroids to the patient, and prior to that in class 5 there would be nephrotic syndrome manifestations. Now, when it comes to A manifestation, the A is being utilized 2 times. One, you get a non-scarring alopecia. I would like to highlight that for the sebaceous glands and the sweat glands, there was atrophy. So that is like scarring. But for the alopecia, it's a non-scarring alopecia. I repeat that again, dermat, right? The discoid lupus erythematosus would have scarring, the atrophic scarring because of the sebaceous and the sweat glands getting lost. But the alopecia part is non-scarring there. And then you get an autoimmune hemolytic anemia. How will he describe autoimmune hemolytic anemia will be, one, he can mention a peripheral smear finding. The peripheral smear finding of autoimmune hemolytic anemia is spherocytes. Now, traditionally, when you read about spherocytes, it's like hereditary spherocytosis. Agreed, but that's for a child. If I teach you adult patient is having spherocytes in a peripheral smear and their musculoskeletal complaints, skin involvements, then it is like lupus associated with autoimmune hemolytic anemia. And these spherocytes are like smaller than the routine RBCs. I'll just zoom into the slide as well. But before I do that, I would like to write a second description how the examiner will write it in the options. That would be a Coombs positive hemolytic anemia. And then lastly, to finish the mnemonic BRAIN, you can see this is like the mnemonic was MDSOSP brain. So this is IN here. IN is the immunological features where like the must like entry level criteria. Whether he says must have criteria, entry level criteria, screening test for diagnosis of this condition. Nowadays we have a scoring pattern where like each parameter is graded for a particular number of marks. There's an app in which each of the manifestations like lupus nephritis will take the top spot and ANA will take the top spot. I mean, those are like the main things that help in diagnosis of this condition. So we have like online scoring platforms available on which we can feed these clinical details and make a diagnosis of systemic lupus erythematosus with confidence. And now I would like to go into this image. So when you check out this image, like what you have to see is one, you can see a cell a little in the periphery. I'll use a finer font here. This is like a white blood cell. The nucleus is not very stained blue, but yeah, for reference, we are taking this as a white blood cell. And this cell is much more smaller than all of these. Like the pathologist will always take care of the reference as a small lymphocyte versus RBCs. And what I want to check out, what I want you to appreciate here is, especially where the black arrow is present, like if I draw with pink color, like it will become more obvious. Normally, RBCs always have a central pallor, but there's certain RBCs very characteristic that you can see in certain areas where they're smaller in size, and they're lacking the central pallor. There is a lack of central pallor. So what I want to bring to your attention is that a normal red blood cell will always be having a central pallor. If the central pallor is missing, that implies that it is a spherocyte, and obviously it has to be smaller than a routine red blood cell also. So at a couple of sites, if you check out, like I put it one at 6 o'clock, one at maybe 12 o'clock or 1 o'clock position, I've tried to show some cells which are called as spherocytes. Spherocyte is shorter than a routine RBC and it lacks a central pallor, and this is written as autoimmune hemolytic anemia. Plus what you see here is those vegetations that I was talking about, right, attached to the caudate tendinae. Caudate tendinae are attached to the undersurface of the valves. So this is like the mitral valve getting damaged by fibrin based vegetations which are predominantly focused on the inferior surface, and that's why we get this sterile endocarditis in these patients. The blood culture in this condition would be sterile, unlike in infective endocarditis where we get growth of bacteria. Now, once we've taken care of the clinical domain, we'll focus on the antibodies which are present here, and the antibodies are like as follows: anti-nuclear antibody. And for anti-nuclear antibody, like the questions are pretty straightforward, so let's just practice them here. The same thing can be asked three ways. One, he can say, what is the most sensitive test for diagnosis of SLE? Your answer is anti-nuclear antibody with the titer values more than 1:80. Whether I say most sensitive, if I say what is a screening test for diagnosis of this condition, or I change the language and I say entry level criteria for diagnosis, the answer is uniform. This would be anti-nuclear antibody. The data is like they're just using English to change the terminology. I mean, change the way the question is being asked, but then the gist of the question still remains the same. Now, if I change it to the most specific antibody, sensitive is for true positives and specifics are for like the false negatives part. So the most specific antibody which will help in confirmation of diagnosis is the anti-Smith antibody. And then there's an antibody in between by the name of double-stranded DNA. So like the query of students is, if you have already made a diagnosis, what is the need for getting a double-stranded DNA antibody done? Like that was having a homogeneous pattern. So like the rationale of doing this, if the diagnosis is made, like, the question is right, why should we do this test? Is because this is going to tell you regarding the progression of the disease. It is used for monitoring the progression, because see, all autoimmune disorders have a waxing and a waning course. Sometimes the disease will become more severe, sometimes the severity of the disease will become lesser. So for monitoring the progression of the disease, what I would like to do is an antibody against double-stranded DNA. And I would like to give a parallel example also. Like in diabetes mellitus topic, for diagnosis, we do HbA1c. For diagnosis, we do HbA1c. For monitoring, we do a postprandial sugar. In the same spirit here, for monitoring the progression of disease, double-stranded DNA is done. And then we come to that Rolanevala antibody, the anti-Ro antibody. The anti-Ro antibody is asked two times. One is for obviously the standard data, photosensitivity, but now I'm going to give some real bad news. What I mean by real bad news is that this antibody is immunoglobulin G class, and because it is IgG class of antibody, it can cross the placenta. You know from basic sciences, only antibody that can cross the placenta is immunoglobulin G class, and once it will cross the placenta, it will go and attack the heart of the fetus that she's carrying. Look at the horrible autoimmunity that you have, that it is not only attacking the body of this lady, her kidneys, her brain, her joints, skin, RBCs, everything is getting affected, man. Each and every organ of the body is getting affected. And now even the fetus, like she got married, she's conceived now, even the fetus she is carrying, the fetal heart is getting affected. What I mean by fetal heart getting affected is, let's say this is the SA node of the fetus she is carrying, this is the AV node, this is the bundle of is the normal conduction systems that we have discussed. So what will happen here is that this antibody will destroy the AV node. If you destroy the AV node, the manifestation that will develop here is what is called as complete heart block. This is what I wanted to introduce to you, that the baby born to a lady with SLE can be born with bradycardia, heart rate of only 40 beats per minute. I have invested sufficient time in cardiology to explain to you regarding Stokes-Adams syndrome / complete heart block / third degree heart block. The SA node of this baby will be beating obviously like something in the range of 100 or even higher, but then the bundle of his is gonna max fire at only 40, so there would be a fetal bradycardia, and because of this bradycardia, the child will be having low cardiac output and can die also. The only way to save this child would be to put in a pacemaker, and such a small pacemaker for baby may not be available also. So what I wanted to bring to your attention is the term neonatal lupus. The question began like this: what is the manifestation of neonatal lupus? As I explained to you, the manifestation of neonatal lupus is complete heart block in the fetus. And then another question was like, which antibody is responsible for causing this complete heart block? Your answer would be given as anti-Ro antibody. For the anti-histone antibodies, the data has already been shared with you. There are certain drugs which would be, this is seen with DILE, that is drug-induced lupus erythematosus. And as far as the mnemonic is concerned, I'll just mention it for the sake of completion. Hydralazine, you can practice with me. Then is isoniazid, then is procainamide, then was minocycline, right? Then there was another M also present there, and then there was a Q. The Q was quinidine. Quinidine is also an anti-arrhythmic drug. So what I want to specially bring to your attention is that procainamide and quinidine, both of them are class A anti-arrhythmic drugs which could be responsible for the issues there. And the one M that I missed here was methyl dopa, alpha methyl dopa for PIH. I missed it deliberately to see that were you picking it up, and are you listening to me carefully or not? Okay, now is the antiphospholipid antibody, which will be responsible for bad obstetric history. So when you will read the data, the question will also say that a lady with lupus has been having recurrent abortions. The definition of recurrent abortions would be like more than 3 consecutive abortions, like at maybe 10 weeks of gestation, she lost the baby. Or the question could mention about intrauterine death also at 34 weeks. So this lady is like literally in tears. She says like, my last pregnancy, 1 month before the delivery, expected date of delivery, we were very excited. We were planning to book a hospital, and like I could not feel my baby moving. I said, okay, then what happened? She says, I went to the gynecologist. She said like, we'll do an ultrasound and Doppler and let you know. And she says the gynecologist rudely told me, your baby is dead. She says, I got the shock of my life. Like, we were planning dresses for the baby, name of the baby and all those things. And the gynec is telling me that your baby is dead. And she's in tears. She says, I had to go through the process of delivering a dead baby. They told me, sign up papers. If you don't agree, you'll go into DIC. You know that if the baby dies, the lady can go into disseminated intravascular coagulation. So now she's like, doctor, why this has happened to me? Why did God cause this problem in me? So you'll say, obviously, I can't be God and like change things, but you'll have to explain to her that, ma'am, in your body, there are antibodies, antiphospholipid antibody. In fact, I would like to mention some more names there. This antibody that I'm writing at the moment will contribute to clotting cycle getting activated. That is anti-cardiolipin antibody. Another one that is seen is called as anti-beta-2 glycoprotein. These antibodies, guys, what they are doing is that while this patient is sitting on in a consultation room across me and is discussing her problem. I am explaining to her, ma'am, that in your body we have anti-phospholipid antibody, we have anti-beta 2 glycoprotein, anti-cardiolipin. She says, sir, what are you talking? I don't understand the names of all these things you're telling me. Can you tell me, doctor, in simple English, what do you want to say? I will tell her, ma'am, these antibodies are activating your clotting cycle. In a normal person, the clotting process is activated when there is some trauma. Like suppose you are like shaving in the morning, you get a cut from a razor, you fell down, there is some local bleeding happening. When you get injured, there is a clotting process activated. Here there is no injury, patient is sitting across me talking to me, and these antibodies are activating the clotting process and are causing development of thrombosis in our uterine artery and the uterine vein. And because of the thrombosis of the uterine circulation, that is of the uterine artery in the uterine vein, she will undergo an abortion or an intrauterine death. She says, are you serious? You tell me that I'm sitting across you and like in my body the clotting cycle is activated. Can I have this again? I said, yeah, this can happen next time also. So in antiphospholipid antibody syndrome that I'm trying to explain to you at the moment, in antiphospholipid antibody syndrome, which is the terminology that I wanted to introduce to you, you could be having it in association with SLE, where you have anticardiolipin, anti-beta 2 glycoprotein, you have lupus anticoagulant, another antibody name that I want to, this is an alternative terminology that I'm using for antiphospholipid antibody, lupus anticoagulant. But what you have to understand is, I said 3 antibody names: lupus anticoagulant, anticardiolipin, anti-beta 2 glycoprotein. They all activate clotting process and will cause consumption of clotting factors. So what will happen in the patient is thrombocytopenia. I'll give another example. All of you read about DIC, disseminated intravascular coagulation. उसमें भी platelets consume हो जाता है ना, like in DIC the platelets gets consumed. Here also in antiphospholipid antibody syndrome, due to thrombosis process, platelets get consumed, so you get a thrombocytopenia. And this lady in future can not only be having like a recurrent abortion, she can have a MI, she can have a stroke. Look at the horrible things I'm saying. At 25 years of age, a lady in future can develop a MI, she can develop a stroke. That is why low dose aspirin might be required in these patients on a lifelong basis. Patient is saying, are you crazy, doctor? Lifelong? You're telling me 25 years of age. I said, ma'am, I want to prevent bad events in your brain circulation and cerebral circulation and like other body circulations. I mean, low dose aspirin is required in these patients. And then obviously we need to give warfarin and heparin in the next pregnancy. You are very well aware of the fact that you cannot be giving warfarin in the first trimester of pregnancy because of fetal warfarin syndrome, and heparin would be given in the first trimester. There is no role of steroids, guys. There is no role of steroids. That again is a question. In antiphospholipid antibody syndrome, what is not gonna help at all? He'll give you all the story. Lady is crying, she lost her babies, 2 babies by abortion, one by baby means like it was a fetus only, so she had recurrent abortions, she had IUD, and he says what will be used for management except so aspirin. In future you have to give heparin, warfarin, but there is no role of steroids in steroids don't do anything for clotting process, man. So it has to be antiplatelets and anti-clotting drugs which are to be used. Then is those anti-erythrocyte antibodies that I've already spoken about. So this will cause a progressive pallor. Like this pop singer was saying, I was taking iron supplements, still I was becoming pale day by day. I went to my hemat, they said, okay, we'll do some tests. And then turned out she was having a Coombs positive hemolytic anemia. So they started investigating. Similarly, the antibodies will turn against self-platelets. So you could have petechiae. I mean, you guys would have read, you and me read petechiae with dengue hemorrhagic fever. Today I'm telling you autoimmune disorder that is causing petechiae and purpurae. Due to gravity, petechiae and purpura will be mainly concentrated initially around the ankles and then can involve the upper part of the body. And yeah, when the platelet count becomes critically low, you could be having like manifestations like epistaxis as well. Then you have antineuronal antibodies present. I've already explained to you cognitive impairment. They can be seizures also, headache also, migraine-like headache. And now what I say is the most important data on this particular slide. I would rate this slide as the most important slide of the topic of SLE, but this that I'm saying is must know for you guys. This antibody by the name of anti-ribosomal P is responsible for development of neuropsychiatric manifestations that will develop in these patients like depression and psychosis. You would have read about depression, you would have read in psychosis and psychiatry, but this is the first time that you would be reading about an antibody causing depression and an antibody causing psychosis, anti-ribosomal P. Yes, guys, the question will say neuropsychiatric because person is always sick and neurological features cause a lot of emotional trauma on a person. So the neuropsychiatric manifestation. Either he will write the word neuropsychiatric manifestation, or he will say like depression slash psychosis present in a lupus lady. What is the antibody responsible? I mean, first time when we read it, it's like, are you serious, man? You telling me that antibody is causing depression? But that is how it is. So I would rate it as like the most, because this is the one that most people tend to forget. See, by English, no, anti-erythrocyte थोड़ी ना गलत करोगे यार. Anti-platelet antibody is like super super easy, man. That's you not gonna forget. So it's anti-ribosomal P antibody that is to be given the respect that it deserves. And yeah, like there's no role of steroids with the anti-phospholipid antibody. We don't give steroids if there is a psychosis. I was saying no, steroids are very, very good for lupus nephritis. I have to start them in like class 3, class 4 deterioration, and no role in subsequent ones. But now I'm saying there's no role of steroids in like if there's a full-blown psychosis or there is like manifestations of antiphospholipid antibody syndrome. I mean, you can't prevent clot formation there. Now, as far as the ANA patterns are concerned, guys, you are like, you're aware of this from pathology, but I have to still incorporate in this slide the uniform homogeneous pattern. That uniform bright staining would be for double-stranded DNA and antihistone antibodies, whereas the speckled and the granular dots in the nucleus are valid for anti-Smith antibody. That's at least one from the lupus perspective to be remembered. SSA and SSB antibodies, they're also called as Rho antibodies and ROLA, right? The name is ROLA. When I say the word Rho and then La, then it should always click SSA and SSB. We will speak about these antibodies even later part of our discussion when I talk about that dry eyes and dry mouth wala syndrome, that is S. Jogren, then the names will come up again. But at the moment, the two patterns of homogeneous versus the speckled granular patterns are like different from the nucleolar pattern. I mean, they're much more bigger, right? If you look at the green dots there, they're like much more bigger which are present. And then you have those polka dots appearance with respect to centromere antibodies, all through uniformly present. So if you look at the presentation there, especially with respect to the homogeneous versus the nuclear versus the centromere one, there's a gross difference in the physical appearance with respect to the antibodies there. The centromere is like super easy, anti-centromere antibody seen in CREST syndrome, so C and C to be remembered. But for the nuclear part, you need to remember it is seen with scleroderma, and for the homogeneous part, you need to remember seen with double-stranded DNA and anti-stone antibody. I have already explained to you that the male to female ratio 1:1 would be seen with drug-induced lupus erythematosus. So it is DILE, not DLE, discoid lupus erythematosus. Then is a question where he said young female presents with a lesion that worsens after hot drinks and going in the sunlight. When I zoom into the lesion, it looks like acneiform lesions. If you check out the lesions here, there is acneiform pustules that are present on the skin, comedones that are present. This is not that butterfly rash. I mean, you can see in this particular area, there is no rash present in this particular area. That classical butterfly pattern is not being present. And then more importantly, saying the lesions are going to be worsening after hot drinks. This flushing that he's trying to explain. So the only disorder where you get flushing and you get acneiform lesions, then my answer would be given as acne rosacea. Like the common error in this particular case is to not pick up the acneiform lesions on the convexities of the face, on the cheek, on the chin, on the forehead. The acne rosacea lesions, though I'll call this more core of a dermatology question than a hardcore general medicine one, but then those convexities of the face involvement and the flushing episodes which are associated together, the combination of flushing. Though you read flushing in carcinoid tumor also, but there the things are different. No, I mean, there it's not going out in the sunlight. You get flushing episodes just like that. Asthma manifestations are given. So no reason for confusing it with carcinoid syndrome. I'm saying flushing with acneiform lesions present in a question, then you have to answer, and especially a female patient or even a male patient given for that matter of fact with those comedones, you have to answer it as acne rosacea. Now the next disorder that I'm going to describe before you is scleroderma. For scleroderma, certain manifestations are very, very characteristic. So let's first focus on them. One of the manifestations is like in our fingers, we have these transverse creases. In patients of scleroderma, what will happen is that there is loss of this interphalangeal joint creases. IPJ means interphalangeal joint creases would be lost in the patient, and therefore the manifestation is called as sclerodactyly. This term you would have read multiple times, sclerodactyly, but like the meaning is that there is loss of IP joint creases, and sometimes they can be ischemic digital ulcers also. Because in this condition there is fibrosis below the skin, you can see that it looks unhealthy skin, which is also called as like pepper, salt and pepper skin. I can say like salt and pepper. Like this term salt and pepper is very liberally used by pathologists as well as in like dermatology. But today even I am taking the liberty of describing that salt and pepper appearance of the skin with some areas of hypopigmentation and hyperpigmentation alternatively present. Scleroderma as the disease causes loss of autoregulation of the blood supply of the tip of the fingers. So when these patients will put their hands in cold water, when these patients will be putting their hands in cold water, or if this person stays in a foreign country and went out at -20 without wearing gloves, then the tip of the finger will exhibit an exaggerated vasoconstriction and the tip of the finger will become first white. Now, because there is less blood supply, vasoconstriction happening, so the level of deoxygenated hemoglobin will rise. When the levels of deoxygenated hemoglobin will rise, you can see that there is a development of cyanosis. The fingertip will turn blue, and then subsequently there will be a paroxysmal vasodilation, because of which the fingertip will turn red. I said color sequence being first there is a exaggerated vasoconstriction, then there is like critical levels of deoxygenated hemoglobin created causing cyanosis, that is blue, and then because of the critical level of cyanosis, critical level of hypoxia, there's an exaggerated vasodilation, due to which there's a change in the color in the fingertip, which is called as Raynaud's phenomenon. With respect to scleroderma, one of the early manifestations that is seen, one of the earliest manifestations that is seen in this condition, and is also the commonest extracutaneous manifestations of this particular disorder, is Raynaud's phenomenon. So we'll be advising these patients to wear gloves, and like we might even start them on calcium channel blockers. In fact, like because the disease is affecting the blood supply of the tips of the fingers also, so one investigation that you can see, like this is normal capillaries, nail fold capillaroscopy is the investigation that is shown here. I mean, these two images, if they're given with respect to scleroderma, then you will say that this is nail fold capillaroscopy. What happens in this particular disorder is that even like the small blood vessels, even the capillaries, and like the distal blood vessels are affected by this autoimmune disorder. So when you do this nail fold capillaroscopy, you can notice that with respect to the nail blood supply, normally you see very well oriented blood. They literally are looking like villi, and then there is a lot of like micro hemorrhages, and there's a fragmentation of these blood vessels, like fragmented appearance of the blood vessels that are seen. So I just want to say that nail fold capillaroscopy will be showing abnormal appearance of blood vessels, that is the small blood vessels supplying the nails of the person. Skin changes would be present, sclerodactyly would be present, and the fibrosis which is present in the tip of the finger can also contribute to findings like the question will say leather-like skin. In no other medical disorder will you read these terminologies that I'll be writing at the moment before you. A female patient came to doctor on workup, anti-nuclear antibody is positive. That is will be the destruction. When he will say female patient anti-nuclear antibody positive, what are you thinking, SLE? But then he will say Raynaud's phenomenon. When she goes out in the cold, fingertips have Raynaud's phenomenon. When the doctor examined her hands, he noticed loss of IP joint creases, that is sclerodactyly. Ladies having leather-like skin. There is development of contractures in the hands of these patients. Normally you read about contractures in burns or like neurological deficit. I'm talking about fibrosis below the skin which is contributing to this. Even when you flex the arm, extend the arm of the patient, the movement of the tendon, because there is fibrosis with respect to the tendons also, like the biceps brachia tendon is getting involved, the question will use the word tendon friction rub. Guys, you are not going to read these words anywhere else. Female ANA positivity will be a destruction. Then is Raynaud's phenomenon, leather-like skin, contractures, tendon friction rub, I mean, you read about pericardial friction rub. You read about pleural friction rub. I'm teaching you tendon friction rub. Very shocking, right? And then he says that when this lady has to bite into a McDonald's ka Maha burger, she can't even open her mouth. Look at it. A lot of fibrosis occurring around the mouth of the patient. She is not able to even open her mouth. So I can also say the word microstomia. At this moment, I want to say that two times, I mean, they might describe like the person is having difficulty in opening a mouth. One will be a guy who does betel nut and gutka and an oral submucosal fibrosis. If you listen to those integrated videos of mine at any point, if you get an opportunity, I've described in surgery part, I've described pre-malignant lesions of the oral cavity, including oral submucosal fibrosis seen in a gutka chewer and betel nut chewer who takes pan parag and all those things, because Salman Khan takes it and all these big actors take it. Therefore, like this guy thinks it's cool. So there the difficulty in opening mouth is described. And second would be they might put a ruler here also, no? Like there's a possibility that in the paper when they give this image, there might be a scale attached to like the mouth of the patient to show that the mouth is not opening, microstomia. So these are like very classical manifestations that you see in a question given of scleroderma. And the screening test for this condition is, as I've already explained to you, anti-nuclear antibody. Raynaud's phenomenon, as explained to you, where we will use calcium channel blocker, amlodipine in low dosages. I will ask the patient to use gloves, avoid exposure to cold, but then Raynaud's phenomenon may still not be treated. So I might have to use CCBs in a patient. This is the earliest and the most common extracutaneous manifestation of scleroderma along with these manifestations. These patients have increased risk of development of lymphomas. Increased risk of lymphomas is always seen with like scleroderma, and one more disorder that I'll discuss subsequently. I'll not mention the name at the moment, but I want you to keep a tab on that. That's the incidence of lymphoma, especially non-Hodgkin's lymphoma, is increased here. Now, what is the most common cause of death in scleroderma? In SLE, I take to you first two answers. If the diagnosis is made and like patient dies within next 4 or 5 years, it is kidney involvement. After like 10 years onwards, it is cardiovascular mortality. Here, the leading cause of death is pulmonary artery hypertension. This disease can cause fibrosis everywhere. If it can cause fibrosis around the mouth, it can cause in the mouth, so saliva production will be less. It can cause esophageal involvement, so esophageal dysmotility would be seen. It can cause fibrosis in the pulmonary artery, so pulmonary artery hypertension can be present in these patients, and this is the leading cause of death in scleroderma. How will the examiner write the word pulmonary artery hypertension is what I explained to you next. He may write the word loud P2. He may write the word DLCO, diffusion capacity of the lung for carbon monoxide is less. He may mention a murmur of this, that is like a Graham Steele murmur. What I just want to bring to your attention at the moment is that pulmonary artery hypertension is defined as, I'm not saying it, I've discussed that in cardiovascular pressure, more than 20, drug of choice if it is used is bosentan or ambrisentan, and we use an inhaled nitric oxide test for this condition, not exhaled. Exhaled nitric oxide test is for asthma. Exhaled, E for England. Inhaled nitric oxide test is used for diagnosis of pulmonary artery hypertension. But at the moment, I've mentioned how the examiner can write from the clinical domain pulmonary artery hypertension, but I covered 5 MCQs for PH right now, right here. Then the drug of choice for scleroderma crisis. Now, what is scleroderma crisis? The kidneys in this condition will begin to shrink because of the fibrosis that will affect the kidneys. Just like in SLE, kidneys are affected. Even in scleroderma, the kidneys are affected. There is fibrosis everywhere. Fibrosis in the lungs of the patient, in the pulmonary artery, around the lips of the patient, in the fingertips of the patient, everywhere, no, even in the tendon areas. So fibrosis of the kidneys will cause GFR to become less. If GFR will become less, RAS will be activated. That activation of RAS will contribute to development of hypertension. So therefore, these patients will be developing a hypertensive crisis and I need to manage it on a war footing. This is the first time and the last time that I'm teaching you a hypertensive crisis for which I'm not telling you to remember intravenous drugs. For all varieties of hypertensive crisis, I've always talked about intravenous drugs. IVs like nicardipine, nitroglycerin, sodium nitroprusside, like that. This is, you can't give IV drugs daily to somebody, right? I mean, this is a chronic disorder. So when he says patient is having scleroderma crisis, creatinine is rising, what would you do? Your answer is ACE inhibitor. Don't answer ACE inhibitor if the potassium is very high, but creatinine high chalega, you can still give ACE inhibitor to a person. So like in the MCQ you will notice is given serum creatinine of 3, like 3.5, but the kidney is damaged, so chalega, we have to give ACE inhibitors to neutralize the high renin hypertension. Guys, like on reading the word crisis, what I find is a lot of students, they they get like overwhelmed by the word crisis and they answer it as parenteral drugs. I said don't answer parenteral drugs here. Then there's a special antibody which is present here. This antibody which increases the risk. Another antibody added to your vocabulary. This is called as anti-RNA polymerase 3 antibody. This is also beginning with the alphabet R only. No? The previous one that I taught you, that antibody was anti-ribosomal P antibody for that neuropsychiatric manifestations, depression and psychosis. Now it is anti-RNA polymerase 3 antibody. Then this disease can cause lung involvement also, and the lung involvement is non-specific interstitial pneumonitis. In rheumatoid arthritis, I'll be describing you another format that is called as UIP, usual interstitial pneumonitis. You can skip for like these 2 points at the moment. Like if you are like feeling overwhelmed by the kind of information that you're saying, if you are like preparing for FMJ exam, again you can skip these 3 points that I'll say next. But for NEET PG, obviously you need to remember the entire data, that what is the pattern of interstitial lung disease. They love to ask it because it's scattered information, no guesswork here. Now you have to remember it. Scleroderma, female patient, NSIP, non-specific interstitial pneumonitis. In RA, it is UIP. And then are drugs causing SSC like features, which are like bleomycin causes pulmonary fibrosis. No. Why is he asking that? Because I taught you regarding drug-induced lupus. He's asking you drugs which can cause systemic sclerosis like features. Just like you are comfortable with that HIP and MMQ mnemonic that I told you for drug-induced lupus, I'm trying to build up your database for drugs that can contribute to SSC, scleroderma-like manifestations. That is bleomycin, pentazocine, that's Fortwin, and then is Fortwin, no? Fortwin that we use as a painkiller brand name, and then is cocaine, which can contribute to systemic sclerosis-like features. So these 3 questions are like, more I would say going in favor of that NEET PG and INISTAT kind of pattern. But rest is common, sir. FMG exam is like, मैंने बोला ना वो what he's doing in the paper is like that Lay's का chips के जैसे फुला देता question को, and it's, believe me guys, people lose patience because of that कि पढ़ने में time लग गया. So reading skills have to be faster, man. I mean, we can't, and that's why like it's a good thing that you're listening to me in the English format, because a lot of guys, what they do is they try to listen in Hindi part, and then like the translation part in your brain will take 5 to 10 seconds, and that delay every 10 seconds you add up, you have large number of questions in the paper, people are not able to figure it out. So what I've said till now, like must know information for scleroderma, and then I've described regarding like 3 optional questions which if you want to remember are okay. Now coming back to the topic, like I described scleroderma. Now I'm telling you cousin brother of this condition, which is having 5 manifestations that are called as CREST syndrome. In CREST syndrome, one way to solve the question is like you have to go the hard way and remember all the 5 manifestations. That is, C is calcinosis cutis, that is calcification in the skin. R stands for Raynaud's phenomenon, where the color sequence is white, blue, and red. E would be for esophageal dysmotility, because of which the person would be having dysphagia described here. This would be dysphagia in a female patient. So you might think in terms of achalasia cardia, but then achalasia cardia does not have a Raynaud's phenomenon and calcinosis cutis associated. To make your life easy, he will then also say that the patient is having loss of creases on the IP joints, that is sclerodactyly. And then there would be dilated blood vessels on the cheeks of these patients. These cross superficial small blood vessels that are seen on the cheeks or on the face areas called as telangiectasia. So one way to correct the question is to remember the full form of CREST. Second is, when he will describe this female patient, elevated ESR, all these manifestations, he will have to give antibody also. The antibody which is present here has to be remembered from alphabet C. Anti-centromere antibody, C for CREST, C for anti-centromere antibody. So this would make your life relatively much more easier. And at this point of time, it's also my job to add up the data for what is the investigational choice for diagnosis of systemic sclerosis. The investigational choice for diagnosis this disease is either written in MCQs as scleroderma, or it is written as systemic sclerosis. Even if you're not remembering all the manifestations that are spoke superiorly, though they're very classical ones, including pulmonary artery hypertension, chalega, but you cannot be expected to forget this name. This name is anti-topoisomerase antibody. Guys, even if you don't remember anything on this page, chalega, but you have to remember 2 minimum points on this slide. Investigational choice for systemic sclerosis is anti-topoisomerase antibody, and the investigational choice for CREST syndrome is anti-centromere antibody. There's an alternative terminology that I would also like to introduce called as anti-SCL70. You will hardly ever see a MCQ on the same, because SCL, English से कर लेंगे ना, scleroderma 70, right? So you're still able to figure it out. So I'll repeat what is minimum expected out of you on this slide. Zooming out of the slide for the topic of scleroderma, 1 page entire data is concised. minimum to be known is anti-topoisomerase antibodies for diagnosis of scleroderma, anti-centromere antibody for diagnosis of CREST syndrome, and the leading cause of death is not kidney failure, is not to be answered as scleroderma crisis. It is to be answered as pulmonary artery hypertension, which could be written in the expressions that I have currently explained to you. Now we will focus on another important rheumatic disorder by the name of dermatomyositis. In dermatomyositis, the question would be like full of visual imagery. What you can notice on the knuckles of the patient is a pathognomonic feature here. What you can see on the knuckles and the interphalangeal joints here at the moment is not loss of any creases. Like you can see, there is no crease loss that is happening, but what is seen here is rather presence of those papules, which are like famous even from dermatology video lectures, that is Gottron papules. Then you can also see a erythematous rash on the V of the neck and on the neck of the person. So this would be called as like a shawl sign, or at the moment I can call it a V sign on the neck, and like even on the shawl or the chunni area, like this rash would be present. Apart from the skin manifestations, you will also notice that the skin around, like there's like a purple discoloration around the eyes of the patient. This purple discoloration around the eyes is what is called as heliotrope rash. So in SLE, the rash was on the nose and was spilling onto the cheeks. Here it's a heliotrope rash present, guys. This is like a super easy topic. Dermato manifestations are gonna be like Gottron papules, V sign, heliotrope rash. And then the question will also say that this lady is having difficulty in climbing stairs. He might give a muscle biopsy finding in this patient, because we do a MRI guided muscle biopsy because myositis component is also present. So I will focus on like the histopathological finding, but even if you are like, looking at this slide casually, you will notice that all the blue infiltration is focused in this particular area where like the blood vessel and the connective tissue is present. If you look at this particular area that I'm marking at the moment, there is no neutrophilic infiltration, but the neutrophilic infiltration is restricted to like a particular area in and around the blood vessels. So therefore in dermatomyositis, like from the histopathology perspective, he will always mention the word perimycial and perivascular involvement. I repeat the statement again, though I'm sure you would have read that in pathology. In dermatomyositis, the infiltration of the cells would be focused mainly around the blood vessels and perimycium. In contrast, when I'll teach you about polymyositis, I'll come up again. Then around the individual myofibrils, these are like the individual bundles. These are the individual myofibril bundles which are present. So around these individual bundles, you can see blue cells present, which is called as, endomysium. So endomysial involvement. Endomysium showing a neutrophilic or like a autoimmune damage is endomysial involvement. And if the damage is restricted to in and around the blood vessel, then that's a feature with dermatomyositis. Going up in the slide, Gottron papules, V sign, heliotrope rash are like in your face features of dermatomyositis with put star mark on Gottron papules because this is pathognomonic. Plus what I've also shown on this slide is just marking it here. This would be a perimycial inflammation. We will be like not doing randomly any muscle biopsy. We'll be doing a MRI guided muscle biopsy in this condition. Most patients would be saying that I was earlier very fit and active. I could go up and down the stairs of my house 10 times per day. But now like climbing stairs is a Herculean task. So after giving all this theory, obviously the diagnosis is dermatomyositis. तो पूछेगा क्या, बोलता है which antibody will be seen in this patient. And before I write the name of that antibody, ex NEET PG question, guys. I think you're all aware dermatomyositis patients have increased risk of ovarian cancer. Both polymyositis and dermatomyositis have increased risk of ovarian cancer. The most specific antibody that is seen in these patients is called as anti-Me2, short and sweet, Mission Impossible 2, MI2 antibody is present here. Now, for those of you who are preparing for INISAT, a question that came in the paper was where there was manifestations of polymyositis described. Polymyositis was like difficulty in climbing stairs. Then he said muscle biopsy was done and it showed an endomysial inflammation, and along with that features of scleroderma were given. I repeat my question. This is specifically for those people who are preparing for INISAT. The question, what it did was that he mentioned patient was having difficulty in climbing stairs, physical fatigue, etc. So doctor did a MRI guided muscle biopsy. Slide was given. Slide showed endomysial inflammation. This is perimycial endomysial inflammation. Then he mentioned that the patient is also having like features of scleroderma were also described, like Raynaud's phenomenon and like leather-like skin, crepitus, or like tendon friction rough. So a lot of my students were confused because they said, sir, When I read the question, I thought initially like this is a question on myositis, but then the question also had features of scleroderma. So this is like a polymyositis scleroderma overlap syndrome that is needed to be answered here. I'm making things a little difficult for you. If you're an FMG student, you can skip this line. But yeah, if you're for INISET, you have to remember the combos also. Like they can give you a question where there's a combo of myositis and scleroderma together. The antibody present there would be called as PM/SCL antibody, and that would be a overlap that would be present. So this might be little difficult maybe to remember at the moment, but yeah, just if you try and remember it, a piece of cake. Then the most specific antibody associated with malignancy, like I told you, the risk of ovarian cancer in these patients is always increased. So the antibody that is present here is also called as anti 155 by 140. The other name for this antibody is transcription inhibitory factor TIF gamma. So you need to remember two names at the moment: Mission Impossible 2, anti-TIF2. If he says specific antibody, NEET PG question, me too. If he says cancer associated antibody, malignancy associated antibody in dermatomyositis, and is anti-TIF. And if it is associated with interstitial lung disease, then it is melanoma differentiation antigen MDA5 antibody. थोड़ा सा मुश्किल है, कोशिश करोगे याद हो जाएगा. Do this with me right now, right here, guys. If you're trying to do this by yourself, won't be possible. Dermatomyositis specific antibody, me too. If it says associated with cancer, then it is TIF, transcription inhibitor. They'll not ask you the full form. Transcription inhibitory factor gamma, also called as anti 155 by 140. As a name, you would not have read a name like this ever before. No, I mean two numbers written with a slash written, very very peculiar. And then for ILD association, it's gonna be melanoma differentiation antigen 5. Initial testing to be done. Sometimes he will bog you down by so much of data. Like the dermatological manifestations are also given, muscle biopsy findings are also given. Then he says, what is the first test? You read the question like bomb. It's gonna throw a bomb at me, and it's like laddu question, right? Myositis. I mean, how do you identify skeletal muscle damage? Creatinine levels, CK. Obviously, like this is CK-MM levels that I'm talking about. CK-MM levels in your entire career. No, you will one answer for that Duchenne's and Becker's muscular dystrophy as an initial screening test, and then subsequently you'll answer it for dermatomyositis. As I've explained to you, there is an increased risk of ovarian cancer in patients of dermatomyositis. And while reading all this, don't be under impression that this is the commonest inflammatory myopathy. No, guys, the commonest inflammatory myopathy seen in elderly patients is to be answered as IBM, that is inclusion body myositis. When I describe the word inclusion body myositis, I also want to say that in all types of myositis, you will always note that it will always be a symmetrical weakness present. Like left and right hip joint muscles both are weak. Left and right shoulder muscle are always weak. It will always be like in all the types of myositis, dermatomyositis, polymyositis, it is a symmetrical muscle involvement. The only question where you get a asymmetrical muscle weakness is inclusion body myositis, where the hand muscles are involved, distal muscles are involved, elbow joint muscles are involved, hip joint muscles are involved, and asymmetrically, maybe on one side more, less on the other. So this is again very peculiar, because normally whenever you talk about rheumatoid disorders, it's always a symmetrical involvement, but this is a asymmetrical muscle involvement. Another question to be remembered is the most common myositis associated with any autoimmune disorder, whether it is SLE or anyone, is polymyositis. That's again like between dermatomyositis and polymyositis, which is more common in association with autoimmune disorders is polymyositis. The slides are important, guys. The slides are important in a sense that if you look at it, endomyosial fibers, and then there is this blue infiltration, and you can notice that some part of the slide is looking totally clean. And then you can see a lot of neutrophilic infiltrate and inflammatory cells in the middle, that is perimyocin and perivascular involvement for dermatomyositis. DM will be a piece of cake for you if you just get the antibodies right. All these manifestations are the filler options in the question. Don't expect he will ask you Gottern papules and pathognomonic feature. I mean, those days are gone. He will ask you about the antibodies. Mission Impossible 2, TIF gamma, and then is melanoma different MDA5. At least like three names are what are to be remembered. Initial testing is CPK-MM, and the risk of malignancy is more, including the histopathological slides. Clinical features are a piece of cake. Mnemonic is dermos, difficulty climbing stairs, proximal muscle weakness. CPK-MB would be elevated. Rash is described, malignancy association. And then the O component is Gottron papules and shawl sign. Shawl sign would mean that even like when we take a shawl, no, some part of the back area can also be involved. So I showed a V sign anteriorly, but then when you take a shawl, the shoulder and the back area also gets involved. So like the skin manifestation can be fairly extensive. Now comes another question, and this time this was asked in FMG exam. So like the question was very funny, guys. Like my student, no, after the paper, he was like laughing it off. Though he was sad at the same time, but he was laughing it off. Ki sir, like, crazy thing. He said, I read the question. Question began by saying female patient and she's having like joint pain, malar rash, butterfly rash. So I thought it is SLE question. Then suddenly in the question, he also mentioned Raynaud's phenomenon. And I was like thinking that आपने तो बोला था Raynaud's phenomenon is not a feature of SL, it's a feature of scleroderma. And then the question also started talking about this lady has difficulty in climbing stairs. So that manifestation of myositis, I was thinking. So he was like, Doctor, I was thinking to myself, what the hell is going on? SLE features were also given. Scleroderma features were also given. Polymyositis features were also given. I said, what did you answer? He said, sir, I did not answer any one of these. There was some peculiar option given, MCTD. I answered that. Am my thought process right? I said 100% right. You see, this guy used presence of mind. He realized that I had explained that Raynaud's phenomenon is a feature of scleroderma, malar rash for SLE, polymyositis, totally different ballgame, difficulty in climbing stairs, endomyosial inflammation. So he said it was not fitting into any of the three disorders. A lot of questions in the paper, guys. I want to make it very, very clear for you, especially if you're an FMG aspirant sitting for first time. Guys, it would be based on exclusion. This is not biology, right? This is not biology. Like xylem phloem नहीं है भाई. Like cotyledon, वही दो चार चीजें होती है ना. और बायोलॉजी में क्या होता है कि लोग 100% स्कोर करते हैं because the data is the same. Medical science is based on analysis. And this guy, he picked it up beautifully. He said, sir, मैं मार्क ही नहीं किया. I marked MCTD. And everybody was shocked. अच्छा, तू ये मार्क करके आया, ये तो आंसर नहीं हो सकता. I was like, no man, this is the answer. Mixed connective tissue disorder. Now, after that, like after that episode, I included this in my notes every time. I mean, like I don't expect a FMG student to be asked this question on mixed connective tissue disorder. भाई SLE पूछ लो यार, मतलब why to make the young guys life miserable? अब they have asked it, तो यार मैं क्या करूँ? मुझे बताना पड़ेगा, right? I have to tell you this, and now I want to tell you that in that question, antibody was also given. That antibody is by the name of, though that guy, he said, boss, antibody नाम नहीं पता था मुझे. I had forgotten even if you are told, doctor, but I was able to solve it by exclusion. So I said, great man, you did a great job. But now I want to bring to your attention the antibody that will make your life easier. Even if you don't remember the features of these three disorders, in rheumatoid, if you get the antibody right, you are sorted for the topic. Yes, guys, that's how good antibodies are. Obviously, you need to learn the clinical domain, but along with that, the antibodies will be like solving it one for you. This antibody is called as U1 RNP antibody. This is called as ribonucleoprotein antibody. While writing it, I also want to bring to your attention another antibody with alphabet R that I spoke, anti-ribosomal P, that was neuropsychiatric manifestations, right, for SLE. Then I introduced that RNA polymerase 3 antibody for like the kidney involvement in patients who are having scleroderma crisis. And now another one with R, ribonucleoprotein antibody. U1 anti-ribonucleoprotein antibody is the investigational choice for diagnosis of mixed connective tissue disorder. Let me just quickly mention the names here, which I would like you to be very thorough with right now, right here. One is anti-ribosomal P, SLE. Then is U1 RNP, ribonucleoprotein antibody, again beginning with R. And then was that RNA polymerase 3 antibody. You will see that when all the names are given together, अभी तो याद रह जाएगा ना, but suppose I say to you, can you remember this 1 month from now? So you have to do it right now. Most important is visual memory of your notes, that when you do a question in your mind should register ये यार ये यहाँ पे पढ़ा था. If you're not able to do a visual memory, that means you are learning superficially, right? Guys, that is important. Just don't underline in the notes. Take running notes. That's very important. Most guys, because printed notes are given, they just like, like acha ho gaya. That's not the way it is. God has given us three lobes of the brain: parietal, temporal, occipital. Occipital to see, temporal to hear and assimilate, parietal to assess the information. Four lobes are there. Use three lobes together. Make notes, running notes. It will make your life easier. Anti-ribosomal P antibody, guys. This was for like SLE, the psychosis component that I described, or the psychiatric profile that I described before you. Then is U1 RNP antibody for mixed connective tissue disorder. And then was scleroderma crisis, which was the kidney involvement that was described. So like because of the overlapping names, I thought I should just mention them at the moment. Now comes that question by the name of S. Jogren syndrome, where we get dry eyes, dry mouth, and dry vagina. This disease affects exocrine glands of the body. The disease affects exocrine glands of the body. It is the lacrimal gland and the salivary gland, and even in a female patient, like the Bartholin glands can be involved. And because of the damage to these exocrine glands, the production of saliva will be less. Lacrimal gland, the tear production will be less, and Bartholin gland damage, then dyspareunia or pain during sexual intercourse can occur. Due to damage to the lacrimal gland, obviously like the tear production is lesser, so they can be like dry eye, they can be a sand like gritty sensation. Like the question will say the patient always experiences a sand like gritty sensation in the eyes. The person is using, like person is thinking I'm working too much on the laptop, no, so that methyl cellulose eye drops डाल रहे हैं, फर्क ही नहीं पड़ रहा है. So that gritty sensation in the eye will persist, and if it's not diagnosed, then even corneal damage can be seen. And because of the saliva being lesser, then two problems can occur. One is difficulty in swallowing. Like he will say that she is having difficulty in eating dry food items. There is a oropharyngeal dysphagia, especially to dry food items like biscuits and chips. You see, if you are eating like biscuit and chip, if your mouth is dry, it will stick to the hard palate. So oropharyngeal dysphagia is described to not all food items. It is described to relatively like dry food items, which are like crackers, chips, biscuits, etc., which are relatively dry, because lubrication property of the saliva is gone. The saliva lubricates the food. Along with this, the question will also mention that the dental hygiene of the patient is getting affected because saliva has bactericidal properties. So there would be halitosis, there can be extensive dental caries in this lady. So he will increase the length of the question by describing these manifestations. Dental caries is caused by excessive growth of a bacteria. I think all of you know the name. Yes, guys, which bacteria causes dental caries? Then your answer is Streptococcus mutans causes dental caries. So initially, like he'll increase the length of this question by describing these manifestations. And then he will also say that even the joints are involved in this condition. So they could be like arthralgia, both in the small joints as well as in the large joints of the body. And then he will ask you regarding a kidney involvement of this condition. It is for this kidney involvement that I want you to remember this disease of dry eyes, dry mouth, and dry vagina. Dry vagina may not happen, but dry eyes and dry mouth would be starting. The kidney involvement in this condition is renal tubular acidosis type 1. In renal tubular acidosis type 1, there is inability to acidify the urine, and this is associated with hypokalemia. Now, I'll not go into how hypokalemia will be occurring in this condition because that I've discussed in the kidney section, but I just want to bring to your attention that RTA4 has a hyperkalemia, RTA1 has a hypokalemia, and there's an inability to acidify the urine. So the urine pH will go towards the alkaline side in this condition. So one S. Jogren is asked in the exam because he wants to talk about the kidney involvement in this patient, that is in the form of RTA, renal tubular acidosis. Though multiple involvements can occur, like they could be autoimmune cholangitis, they can be peripheral neuropathy, but then this kidney involvement is one that they want to hear. And second, what they want to hear on this topic is the diagnostics. Now for the diagnostics, there are a total of 5 tests. How to utilize those tests is a mnemonic by the name of USE. What I mean by USE is, I'll zoom in the diagram. The USE alphabet, the U alphabet is for unstimulated salivary flow. The bottom line is that there is a dry mouth in the patient, so we can estimate saliva flow, which would be less in this patient. You don't need to remember the value, but the point is salivary flow will be lesser. Then because I said the word use, SE is coming 2 times for I. One, you are aware, and you can see in the image also, I put that filter paper, like this is having markings here, and we can see that the lacrimal gland is working lesser. So Shermer's test showing a report of less than 5 mm at 5 minutes. Even that 5 mm at 5 minutes nahi remember hai chalega. And then is eye staining. Instead of ocular staining, I've used the alphabet E, eye staining score of more than 5 using different kind of stains that are available. I want to demonstrate the presence of dry mouth and dry eyes. Dry mouth, how will it be written? Unstimulated salivary flow. How will you write the word dry eyes? 2 ways. Shermer's test of report less than 5 mm at 5 minutes, and the eye ocular staining score of more than 5. 5 number coming again and again, right? Let's do this again. There is dry mouth and dry eyes. So for the mouth, even if you don't look at this data, just mentally visualize. Salivary flow is less, unstimulated salivary flow U. S is for Shermer's test, less than 5 mm at 5 minutes. And the eye ocular score, instead of saying ocular, eye ocular score of more than 5. Among these three, any of these can be present. From these five, any one can be present for diagnosis. Now we move on to the right hand side, use ROM. Now for ROM, what you need to remember is there should be Rho antibodies here. Rho antibodies are found in SLE, but as told you even earlier that Rho antibody will come up again with respect to the description of Sjogren syndrome. And then for the ROM part, I also want to bring to your attention the word salivary gland biopsy. It is a minor, no M. That M part is for minor biopsy, minor salivary gland biopsy that I'm using in this patient. So when we are looking at the data, any of these two can be present in a patient. Let's evaluate use ROM only. I'll just zoom out and focus only on use. Try to remember with me because they asked diagnostic algorithm. They asked that in ENISET exam. Use the unstimulated salivary flow. S is Shermer's test of less than 5 at 5 minutes. E is the eye ocular score of more than 5. In ROM, it was Rho antibody, and ME is for the minor salivary gland biopsy. If you ask me to select one of these and say which of these is best for diagnosis of this condition, then the single best answer that I would like to give is a minor salivary gland biopsy is the investigation of choice for this particular condition. Yes, guys, for like if I just move up the slide, if I have to say what is the IOC for diagnosis of Sjogren syndrome, then the investigation choice which I would like to answer among this would be a labial biopsy. We'll take a biopsy from the inside of the lip. So minor salivary gland biopsy is overall the best one for diagnosis. We can see lymphocytic infiltration. The disease has tendency to involve the exocrine glands, but the diagnostic algorithm goes as use ROM. Use ROM would mean that there are 5 features present here. Any one from the top 3 use, and anyone from like the inferior to or like from the ROM part. ROM, I'll say again, Rho antibody either or minor salivary gland biopsy turns out to be positive, then the combination of these would be diagnosis of Sjogren syndrome. The next point to be remembered for this condition is the association with the DR3, just like DR4 is for rheumatoid arthritis. And the next peculiar thing is rheumatoid arthritis can coexist with Sjogren syndrome. And you are like, what? I mean, the question would be beginning with dry eyes and dry mouth and giving you description of unstimulated salivary flow, and then he will also talk about PIP, MCP and wrist joint involvement present bilaterally. So don't be surprised if you read rheumatoid arthritis. It can coexist with any autoimmune disorder, guys. RA can coexist with any autoimmune disorder. The extraglandular involvement, because it predominantly involves lacrimal and salivary glands, the extraglandular involvement is arthritis. Joints can be involved. It can be both big and small that can be involved. And then there is increased risk of lymphoma. I had earlier also talked about increased risk of lymphoma with respect to scleroderma. I described non-Hodgkin's lymphoma. I'll show that slide again. But at the moment, the type that is associated here is a extranodal marginal zone lymphoma or MALT of the salivary glands. The word is MALT, not in the stomach. If we read about maltoma in the stomach with H. pylori, I'm talking about MALT of the salivary glands. That is lymphoma risk is increased in patients of Sjogren syndrome that they love to ask. So 2 points of Sjogren extra I wanted to remember is association with rheumatoid arthritis and association with lymphoma. Now I will move back in my slide and bring to you that slide of scleroderma, where also I had said that the patient is having increased risk, but there it was a B cell non-Hodgkin's lymphoma risk that is increased in scleroderma. But for this I mentioned MALT of the salivary gland is increased with respect to Sjogren syndrome. If I minimize the data for you, what is the minimum I expect of you for Sjogren syndrome right now is 3 points. Point number 1, kidney involvement is RTA1. That's the first point. Dry ears, dry mouth, you remember, so I don't need to say that. RTA1, that's the first point. Second point I want you to remember is use ROM. I'll say it fast. Unstimulated salivary flow. Then is going to be association with this Shermer's test, eye ocular stain, Rho antibody, ME standing for that minor salivary gland biopsy report or lymphocytic infiltration. And from these, like we need a combo to be making a diagnosis. So that's the second point. And third is association with RA and association with MALT of the salivary glands, that is lymphoma association. Those are like pointers for Sjogren syndrome that should be remembered. Normally in all rheumatoid disorders, I focus on antibodies, but here instead of focusing on the antibody, I focused on like minor salivary gland biopsy. Just like in dermatomyositis, antibodies were there, but initial testing that was done was a MRI guided muscle biopsy to identify the pattern of dermatomyositis versus myositis. Now we come to that very, very classical mechanics hands. The moment you read this word, like he can give an image also. Like if you look at the hands of this person, there's a lot of, like, I can say hyperkeratosis. There's like, because like a car mechanic's hands will come in contact with grease and engine oil and abrasives, so it will cause a lot of hyperkeratosis and drying of the skin present. So this manifestation that is present here is called as mechanic's hands. And along with that, he can also describe breathing difficulty, exercise intolerance in a person due to associated pulmonary fibrosis. The disease I'm talking about is called as ASS, that is anti-synthetase syndrome. In anti-synthesis syndrome, the antibodies are present against T transfer RNA. It is antibodies against amino acyl, full name to be remembered, antibodies against amino acyl tRNA synthetase, and the most common antibody that is associated here is a short name Jo1. In patients of like the previous one, the short antibody name was Me2. I hope you remember that, right? Mission Impossible 2 wala antibody for dermatomyositis. Similarly, now I want you to remember a short name, anti-Jo1 antibody for anti-synthetase syndrome. This question will begin by first describing features of polymyositis or dermatomyositis, difficulty in climbing stairs. Then we'll say that the person is having progressive decrease in physical activity and lung fibrosis is occurring. How will the examiner write the word lung fibrosis? He will say FEV1 FVC ratio of the patient is more than 0.8 and the DLCO of the patient is lesser. The combination of the two is a feature that we get for restrictive lung disease. Then you will try to waste your time by describing the joint involvement and the Raynaud's phenomenon, because they can be present in multiple disorders. But the clinching point in the question which I'm writing in big 5 is mechanics hands would be present. These are the classical core features that are present. You can notice that apart from point number 2, all others are distractors. PMDM findings are distractors, non-recursive arthritis, Raynaud's phenomenon. So don't bother about them. It is like that interstitial lung disease association and then mechanics hands which are to be picked up. And the moment you read the word mechanics hands, you will say antibodies against amino acyl tRNA synthetase. I'll read that again, amino acyl tRNA synthetase, and one of those antibodies is anti-Jo1 antibody that increases the risk of especially the lung disease, that is the association with interstitial lung disease, that is ASS, anti-synthetase syndrome. Now comes overlap syndrome. This part, overlap syndrome, if you are like an FMG student, you can skip and move on to the gout part. But if you are an innocent NEET PG aspirant, hear me out. Overlap syndrome will be a question where he will give you combinations of scleroderma polymyositis. I've given you a heads up already for that. Question began by saying difficulty in climbing stairs. MRI guided muscle biopsy showed presence of endomyosial inflammation, and then there was skin tightening, contractures also described in a patient. So that the antibody will be answered as anti-PM/SCL antibodies. This is overlapping of two disorders. That is scleroderma polymyositis. Overlap syndrome is to be remembered. Then is SLE with rheumatoid arthritis overlap, that is called as RUPUS. Again, very peculiar. RH is rheumatoid arthritis and UPUS is that SLE manifestation. And then you can have SLE and scleroderma overlap as well. At this moment, the minimum that is expected out of you is to remember PM/SCL as overlap, because this is a PYQ of the INISET, and don't mix this up with mixed connective tissue disorder. In MCTD, the manifestations were different. In MCTD, it was SLE, scleroderma and polymyositis. It was overlap from more than two diseases, but then the diseases were very specific. So MCTD is not included in that overlap. Overlap is where those only two diseases are taken into consideration. That would be like, I'll show again PM and SCL. Here it was SLE, scleroderma and polymyositis. Three of them together. If ever in doubt, search for antibody. U1 ribonucleoprotein antibody will make your life a little easier. At this moment, we are now stage set for gouty arthritis, the easy part of the discussion. So my question to you guys is, look at this image. You can see the hemorrhagic crusting of the lips. If you ever get a question in which hemorrhagic crusting and black lips are given, guys, this was asked in FMG exam related to gout. Why? Because one of the drugs that we use for management of these patients can contribute to this manifestation of Stevens-Johnson syndrome. What is that drug? Yes, allopurinol. Allopurinol can contribute to this nasty manifestations of Stevens-Johnson syndrome in a patient. So I will speak about this point again, but if you ever get an image-based question in which I'll write it here also, if you are going to be getting hemorrhagic crusting of the lips Lot of other things will also be given like a rash on the body, etc. But like in the exam, my students had bilkul kala lips tha sir. It was like bleeding, blood had clotted, no clotted blood on the lips. So hemorrhagic crusting of the lips is a feature that you always would be getting with Steven Johnson syndrome. Steven Johnson slash toxic epidermal necrolysis is based on body surface area getting involved. SAS is SJS would be less than like 10% of the body area, and if it's toxic epidermal necrolysis, more than 30% of the body surface area. But yeah, I mean, important point to be remembered that Steven Johnson syndrome can be seen with sulfur drugs, that is okay, but can be associated with allopurinol as well. Then you can see these yellow deposits of uric acid in the skin. These yellow deposits of uric acid in the skin are what are called as tophi. Then if I move a little to the left, I can see polarized microscopy, which will be pink slide that is given to you with that blue and yellows in between. This is a negatively birefringent. This will always be written in all questions related to gout, that negatively birefringent crystals, which are needle shaped, are seen. They're needle shaped because uric acid is very soft, so the crystals will break, but these would be needle shaped, negatively birefringent crystals, which is the one of the main pickup point in an MCQ polarized microscopy finding. And then you can notice the swelling of the big toe. The swelling is gonna be so extensive, guys, so extensive that it will look like cellulitis. This manifestation that I'm currently writing here before you is called as podologia. Instead of writing the word podologia, sometimes he may write the word podogra. Podologia, podogra are like the terminologies which are to be remembered for the gout association. Then can be needle-shaped crystals. Treatment part will be asked and will be discussed in detail, but I initially wanted to give you a heads up with respect to gouty arthritis. Now comes the core information. What are the crystals made up of? Then don't answer plain uric acid. The crystals could be made up of monosodium urate. You see, when I say the word uric acid, a query from one of the students was, sir, uric acid is acidic, so why is the patient's pH not falling? You are saying uric acid is more, so uric acid, if it is more, acid is more, sir, so it should cause metabolic acidosis. I said, buddy, it is uric acid, but it chelates with sodium, and therefore you get a monosodium urate which gets deposited in the joint. So we don't have like a manifestation of metabolic acidosis in this condition. It is crystals of monosodium urate, and as I explained, they exhibit negative birefringence. On a light microscopy, they can be seen as needle shaped because uric acid is very soft. And as far as the triggers for this are concerned, most of the time the question will begin with saying a male patient. In all RUMAT questions, he will always begin by saying, he'll always begin by saying like, it's a female patient, but here he'll usually say a male patient. He's about 60 years of age. This is a male, 60-year-old male, and he was having hypertension. So his physician had started him on thiazide diuretics. Normally, after 55 years of age, we start the patient on calcium channel blockers, but according to the older guidelines, we were using thiazides. So maybe his physician has not updated himself and is continuing with thiazides. And the disadvantage of thiazides is that they contribute to development of, thiazides as a side effect can contribute to hyperuricemia. In fact, I would also like to utilize this opportunity to mention side effects of thiazides, why they're not used now anymore extensively. Obviously, we use them clinically, but not so extensively as they used to be used earlier, because they cause hypokalemia, they cause hypomagnesemia, they cause metabolic alkalosis. Apart from this, they cause increase in blood sugar. Most Indian patients would be having a big problem with that. They cause a deranged lipid profile. They contribute to hyperuricemia. Uric acid levels tend to rise. So because of the adverse metabolic profile of thiazides, therefore they've gone down the preference for management of hypertension, because they cause hyperglycemia, hyperlipidemia, hyperuricemia. All the bad things are more. So Indian patient will suffer. So nowadays we prefer using CCB, but this patient was started on like thiazides only. Or the question could talk about a patient on ATT. Then whenever you read about ATT, two drugs will always be the spoil sport here. One is going to be pyrazinamide, which contributes to pyrazinamide, which results in development of increase in uric acid. And apart from pyrazinamide, the second drug is ethambutol. Yes, both of them, pyrazinamide and ethambutol, can contribute to. Ethambutol predominantly causes optic neuritis, but it can also cause a rise of uric acid. Or he can mention this guy is hypertensive with thiazides. He recently went to a marriage party. There he ate a non-veg. Non-veg would mean that purine-rich diet was consumed by a patient. You're aware that breakdown of purines will produce uric acid, and the guy drank a lot of alcohol also. So it could be one risk factor. It could be combination of these triggers that could be given in a question. 60-year-old guy with hypertension, on thiazide diuretics, on a marriage party in the family for a couple of days. Like these guys were at the roka ceremony and the main ceremony and the reception. Every day these guys are drinking, and all the time he's eating non-veg. So combination of alcohol binge with purine rich diet, and he's predisposed to hyperuricemia due to intake of thiazides. The guy will develop a flare up of uric acid elevation in the joint space, and that will be acute gouty arthritis, which will be so painful that even if the bed sheet will touch this swollen area, the patient will howl with pain. The person was sleeping, woke up in middle of night with extreme pain in the foot, and I was like, "Raat ko aaya patient with pain in the foot." And when you looked at the first metatarsophalangeal joint, it is so red, so inflamed that it literally mimics cellulitis. It literally mimics cellulitis. So what we're discussing at the moment is acute gouty arthritis, and therefore, like these are the triggers which would be described. The clinical manifestations in this condition would mainly focus on, like he will describe this person is having difficulty with ambulation, difficulty in walking, and severe pain at the base of the big toe. And don't be surprised that he will, like, there's a possibility that the examiner himself may not use these terms like podology or podogra. I was trying to make it easier for you. In the NEET PG, the question started with pain in the ankle and the pain in the knees of the patient. He did not even talk about the podology or podogra or pain at the base of the big toe. I mean, this is what we expect the examiner to say. In NEET PG deliberately began by saying patient is having fever and he's having lot of swelling at his one of the ankle joints. So a lot of students were, sir, ankle joint to gout nahi ho sakta na, because gout is involving the big toe or the first metatarsophalangeal joint. So I said, yeah, I mean, that is okay that it involves the first metatarsophalangeal joint. It causes the first metatarsal joint inflammation, but it is not a guarantee that always it is the first MTP involvement that would be present. So don't be surprised if you get a question which begins with fever, and the reason for that fever is like he also had septic arthritis in the option. So couple of guys answered septic arthritis. Yeah, septic arthritis to bachcho mein hota na. Usually it's the hip joint caused by Staph aureus, right? So it's like septic arthritis was there. Uric acid was also there. Though other features of hyperuricemia I'll describe before you were present, but a lot of guys, because of fever and ankle joint involvement, they got a little, I would say, went off the track and missed the question. Now, what is the main test to be done in this guy with a swelling of the ankle joint, which literally looks like cellulitis? The joint is so red, so inflamed that even bed sheet, if it is touching, he can't wear socks, he can't wear chappals in the foot. So what will you do in this patient? The investigation choice is not serum uric acid. Serum uric acid is normal during a flare-up of acute gout because all the uric acid is mobilized into the joint space. So what we will do in this patient is a joint aspiration, and the joint aspiration will then be describing. He then wasted time by saying turbid fluid was obtained. Even then couple of guys were convinced this looks to be like septic arthritis. Turbid because this is inflammatory. This turbid fluid was then mentioned to be having like 10,000 polymorphonuclear cells per cubic millimeter. So because such a high neutrophil count is present, again thinking of septic arthritis. Then he himself said on gram stain, no organisms were seen. Gram staining was done. There was no organisms that could be documented. Then he said when the patient's sample of synovial fluid was examined under a polarized microscope, then it showed negative birefringence. When it was observed under a light microscope, it showed, it was a proper report that was given, right? He did not describe like I am at the moment. It was like needle shaped crystals on a light microscopy. There was negative birefringence that was described on polarized microscopy. So one had to read the entire question before we could come to a conclusion, and the conclusion was like obviously like a gouty arthritis, but then because the ankle was the one that was given to be swollen, so a lot of guys were still in a dilemma, should I answer it as gout or not? Finally they did, because laboratory evidence is always superior. No, I mean, like, I understand that if you say ankle joint involvement or knee joint involvement, you would be in a dilemma. But if the lab report is saying needle shaped crystals, lab report is saying negative birefringence, तो फिर tension क्या है? I mean, we go on evidence-based medicine on the basis of lab reports also, which will be given like more importance over the clinical domain. Though obviously both matter, but yeah, the lab report is like in your face. Now, once the diagnosis is made, we'll talk about the treatment of choice for this condition. So we will be starting this patient on indomethacin. The main drug that is used for management of acute gout is indomethacin. After 1 or 2 days, when the swelling will go down, we can also start the patient on colchicine. Colchicine initially, like I'm not using because it can cause a side effect or diarrhea. So once the swelling goes down in 24-48 hours, then colchicine in the patient can be added. At this moment, I also want to say the fact that allopurinol is not to be given in acute gout. It is contraindicated. Allopurinol is used in management of chronic gout in a patient, but not for management of acute gout. One of the painkillers by the name of aspirin, in fact, I can just write that superiorly, even low dose aspirin. Even aspirin can be a trigger. Aspirin is not to be used. High dose aspirin, yes, you can use, but low dose aspirin can be a trigger. So one more point added, low dose aspirin can be a trigger for development of acute gouty arthritis in a patient as well, apart from the other triggers that I mentioned superiorly before you. And I will manage the patient by giving indomethacin and colchicine. Indomethacin is also used in management of migraine attacks. Now, these patients will get converted into chronic gout. So, in chronic gout, one, you will get these deposits. They can be on the pin of the ear, they can be on the fingertips, as I showed you initially, that is like on the DIP of the patient. These are deposits of uric acid in the skin, that is called as tophi. And then, if you look at this X-ray at the base of the big toe, you can notice like there's a erosion that is present. So, this erosion is basically looks like a rat bite erosion, like rat has bitten and nibbled into the bone. So this is the radiological finding which surprisingly was asked in FMG exam. It's called as Martel sign. Apart from this, the uric acid, like the lesions can also contribute to nephrolithiasis or kidney stones in a patient. Martel sign basically means a rat bite lesion, that is like a bone is totally eroded because of the inflammatory process or joint inflammation. For the workup of patients of chronic gout, yes, I will be doing a serum uric acid in a patient. Obviously, this time it would be elevated, but don't answer serum uric acid for patients of acute gouty arthritis because all the uric acid is mobilized into the joint space. So during an attack of acute gout, I'll write it here. In acute gouty arthritis, serum uric acid can be falsely normal. The reason is that all the uric acid will be going into the joint space of a person. So the mobilization occurs into the joint space, causes monosodium urate crystal deposition and causes that inflammation, recruitment of neutrophils, security system coming in. They thought it is infection, it's crystals of uric acid which are causing the irritation, but serum uric acid is normal in acute gouty arthritis. In chronic gouty arthritis, it is obviously elevated as I explained to you. And then the next test that I'll do is a 24-hour urinary uric acid levels. The reason why I'll do this is because I want to identify that whether the guy is a overproducer of uric acid or is he a under excreter of uric acid. So in a 24-hour urinary uric acid levels evaluation, if I get a report that the values are elevated, that means the guy is a overproducer of uric acid. And in these patients, I need to basically overproducer, I need to give allopurinol to the patient. Allopurinol is contraindicated in a case of acute gout, as I already explained to you. But in a overproducer in a chronic gout, we will be giving allopurinol. This drug is a xanthine oxidase inhibitor. If I inhibit this enzyme, then I will be able to inhibit the production of uric acid. At the same spirit, I would like to say that if the urinary uric acid levels are low, that means that uric acid is not getting excreted, and that's why it is going to be elevated in the blood. So I would like to call this patient as a under excreter. I use two terminologies in English. One is overproducer of uric acid. Second is under excreter of uric acid. For the under excreter of uric acid, the kidney function is not doing well. So I can be using another drug by the name of probenecid. This will help in excretion of uric acid via the kidney tubules of the patient. At this moment, I also want to say that uric acid levels are always increased in patients of CKD. All patients of chronic kidney disease, obviously creatinine takes time to rise. Creatinine is a very specific test for damage to the kidney, but even before the creatinine starts to rise, even uric acid starts rising. So remember, uric acid is elevated even in chronic kidney disease in a patient. I mean, the kidney is not able to excrete. That's what I was saying, no? Under excreter. And at the same time, allopurinol is not to be given. I mean, it is contraindicated in patients of acute gout. It tends to cause a flare up rather. So we can be using the following drugs. One more drug I can say is febuxostat. Again, it will be inhibiting the same enzyme, that is xanthine oxidase. Whenever you are prescribing allopurinol to your patients, you must tell to them that if you ever develop a rash, even chota sa rash or like a blister on the lip and it starts bleeding, stop the medicine, come to me. Because allopurinol is notorious to contribute to development of Steven-Johnson syndrome in a patient. Though traditionally we read about Steven-Johnson syndrome with sulfa drugs and lamotrigine, but today I want to say that allopurinol, sulfa drugs, and that anti-epileptic drug lamotrigine is famous to be asked for development of SJS, Steven-Johnson syndrome, in a patient. Steven-Johnson syndrome will be having hemorrhagic crusting of the lips, as I explained to you, along with extensive rash and desquamation that would be present. If the body surface area of the patient that is involved is less than 10%, then you will say Steven-Johnson. If the body surface area involved is more than 10%, then 30%, then you will say toxic epidermal necrolysis. If it is between 10 to 30%, then you will say Steven-Johnson syndrome and toxic epidermal necrolysis overlap. So what I want to just bring to your attention is, if you ever get a question in which after intake of these drugs, there is like bleeding from these lips also, and then you can also notice chapping of the lips, cracking of the lips, and then like, because clot will look brownish, blackish now, so hemorrhagic crusting of the lips is a feature that's always seen with these drugs that I've currently explained to you. And now we will compare this information with that of pseudogout. In pseudogout, guys, the most common joint that happens to be involved is the knee joint. In pseudogout, he will always see the word positively birefringent crystals. In when I was describing to you regarding like uric acid or monosodium urate, I said the word negatively birefringent crystals. This time we will say positively birefringent crystals. And for pseudogout, we can be giving steroids to the patient. We can also give them intra-articularly because the person is having knee joint involvement. It is causing knee pain. So instead of giving oral steroids, sometimes I can also be writing like IA. IA would mean like intra-articular steroids may be given to these patients. Then a couple of miscellaneous questions like polarized microscopy can identify crystals of uric acid and like calcium pyrophosphate, calcium apatite, but it will not be able to identify crystals of calcium oxalate. I mean, calcium oxalate, no, the one that we have talked about in kidney disease, that would be like here we're talking about joints, right? But in kidney disease, I've described like calcium oxalate stones to be present. So polarized microscopy cannot identify crystals of calcium oxalate. Then high dose salicylates, I explained this already. Low dose aspirin will trigger gout attack in a person, but high dose salicylates do not cause. Remember that statement of mine, that high dose of salicylates or aspirin do not cause uric acid retention. Maltal sign I've already explained to you, that right bite erosion. And yeah, one more good radiological finding on ultrasound was asked. Crazy thing, ultrasound of MTP. Then this is gonna be called as double contour sign. I'll draw parallel with cardiology. Like in cardiology, I've said a double atrial shadow because of mitral stenosis. I'll just write the theory so that you can relate to this better. Double atrial shadow. I mean, normally the atrial shadow will be only of the right atria. Left atria is not seen on X-ray. But here there's a double atrial shadow that is seen because the enlarged left atria pushes the right. This is again a NEET PG question to be remembered. Double atrial shadow is a feature to be seen in the valvular region is mitral stenosis. MS is, okay, let me write the complete form only. Otherwise it will cause confusion with multiple sclerosis. So double atrial shadow is seen with mitral stenosis, and double contour sign is what you see with MTP involvement with uric acid crystals because of the inflammation part. And as far as the factors precipitating gout is concerned, traditional information, cyclosporin, then is alcohol binge drinking and aspirin, low dose, not high dose, niacin, so can, leap, and then Lasix, thiazides, both of them, ethambutol, yes, pyrazinamide and ethambutol, both, I said that even earlier also. Then is alcohol and then purine rich diet. So if you look at the data, Lasix, ethambutol, alcohol and pyrazinamide are like the triggers which are present, apart from obviously alcohol binge and aspirin low dose and cyclosporin. These are like factors precipitating gout or drugs precipitating gout. Alcohol is like not a drug obviously, so that's why the word factor is given here. But yes, this is an important information to be remembered, guys. It looks very simple, straightforward, but then people in the exam missed it out and tended to go so extreme on towards septic arthritis. Though he mentioned no gram stain, they said, sir, because antibiotics might have been given, so gram stain can be negative also. But then you don't have negative birefringence described for anything for like the infective etiology. Now, once we are done and sorted for this, next we'll talk about RA, that is rheumatoid arthritis, where the association is with HLA-DR4. I had spoken about DR3 with respect to the previous disorder. That was when I was describing, like I'll just show the slide also, because otherwise the visual memory is lost. This was HLA-DR3 association with Sjogren syndrome, dry eyes and dry mouth. Now for RA, it's gonna be HLA-DR4. Question for you guys: tell me the antibody that causes rheumatoid arthritis. RA factor is obviously one of the antibodies, but is not the main antibody. Can you tell me the investigational choice for rheumatoid arthritis quickly, guys? IOC for rheumatoid arthritis is, the name of the antibody is anti-cyclic citrulline peptide. Don't mix it up with rheumatic arthritis. Rheumatic arthritis is that group A beta hemolytic streptococcus. Their anti-streptolysin O antibody or ASO antibody is present. Anti-cyclic citrulline peptide antibody. Anti-cyclic citrulline peptide antibody is the investigational choice for diagnosis of this condition. One of the screening tests that I'll be doing in these patients is RA factor. RA factor belongs to which antibody class? Then it is IgM. And RA factor can be biologically false positive in 5% of normal population. Yes, guys, this test is a screening test. However, it can be biologically false positive after a URTI. It can be biologically false positive after recent infection also. So because of biologically false positivity in normal population, it is not the investigational choice. Investigational choice has to be sensitive. It has to be specific also. You can't allow a test to be biologically false positive, but you'll get this question in various apps that what is the class of antibody in RA factor? IgM class of antibody can develop after a sore throat also. So rheumatoid arthritis will always begin by describing a young female. He will first say that she is having morning stiffness and she is always late for her office because she has difficulty in holding on a toothbrush, or like doing morning chores in the patient. It takes longer time. So person is always late for office, like morning stiffness lasting more than 30 minutes or maybe going up to 1 hour might be described. Then he will say that she is complaining of pain in the small joints of the hand. She is not able to hold a toothbrush. Routine chores in the house are affected. Proximal interphalangeal joint, metacarpophalangeal joint, and the wrist joint will be involved in these patients, and the involvement is bilaterally symmetrical. Like today, if she is coming with pain in her left wrist joint, then she will also be having pain in the right wrist joint as well. So it's a bilaterally symmetrical involvement that will be seen. You need to monitor the patient over 6 weeks to identify the pattern of involvement. We do marking every time patient comes with joint involvement. We mark it, and then over a period of time, we are able to see small joints are getting involved, and it's a bilaterally symmetrical involvement. The problem with rheumatoid arthritis is that it is a erosive arthritis, and therefore you could be having development of deformities as is shown in the schematic representation. I'll zoom into the diagram for and use a finer font for describing the deformity that is shown. If you look at this diagrammatic representation, you can easily pick up the swan neck, but he'll not ask you swan neck. He will give you a description. The description is that there is an extension. The extension is occurring at the proximal interphalangeal joint. And you can notice that there is a flexion at the distal interphalangeal joint of the patient. So he will write extension at the PIP and flexion at the DIP. That is swan neck deformity. Now suppose I change the English words. If you look at this representation, then it's different from the previous one. So let me just rephrase this. I can see a flexion at the moment at this joint, that is the proximal interphalangeal joint. And then you can notice that I've tried to show some extension which is occurring at the distal interphalangeal joint of the patient, which has been shown subsequently. You can see that the E and the F alphabets are swapped. So you have to remember either one of the two. I would suggest you to first remember swan neck deformity. Don't look at the diagram. Just at the moment, mentally visualize in swan neck deformity where is the extension. So it would be proximal interphalangeal, and where will be the flexion? Distal interphalangeal. If you invert the data, then it becomes what is called as Boutonniere's deformity. In the question, though this is covered in orthopedics also, I've tried to do my part here. Boutonniere's deformity will be having the following areas, and then I've described a swan neck deformity here as well. So this is like pretty standard erosive arthritis, but I don't want this to happen. because I know this can happen in my patient, because we know this kind of an association can be seen. I want to prevent such a manifestation from occurring by using aggressive treatment. And that is why in rheumatoid arthritis, like, we are aggressive from the management perspective. In fact, most physicians will straight away start tofacitinib nowadays. That's because they get more commission while writing tofacitinib. So left, right, and center nowadays everybody is writing it. But the guidelines is we should be first starting these patients on methotrexate. Like, he will give you this description and then he will say what is the drug of choice for this condition. So drug of choice for management of these patients is methotrexate. If there is no improvement methotrexate, then we will upgrade, and the upgrade would be we will be giving triple therapy to these patients. Now, triple therapy for like PPI with clarithromycin for H. pylori has been discontinued or not recommended because of high resistance in India. So today I'm not talking about triple therapy of like that H. pylori thing. I am rather talking about triple therapy for management of these patients of rheumatoid arthritis. So this again is a repeat question that is to be remembered. A lot of questions of NEET PG are repeated in FMG exam, guys. So if you are an FMG student listening to this, don't think that this is not for you, sir. The questions of NEET PG are being repeated in FMG and vice versa also, but NEET PG wala question in FMG. That is why, like, the tags that you are using, you should do not only FMG questions but NEET PG questions also. So methotrexate and triple therapy would be used. Triple therapy में क्या क्या देंगे तो methotrexate, sulfasalazine and hydroxychloroquine. Yes, the same drug that we use in management of ulcerative colitis and hydroxychloroquine that are described in lupus also would be used in these patients. So MT, sulfasalazine and hydroxychloroquine is the triple therapy to be remembered for these patients. Now, the most common extra-articular manifestation of this condition is development of rheumatoid nodules. The extra-articular manifestation is rheumatoid nodules. These rheumatoid nodules can be seen on the extensor distribution of the body. Extensor distribution can be like the olecranon process. And these rheumatoid nodules are not only in the skin, not only on the extensor distribution like olecranon or in the occiput of the patient, but they can be present involving the heart of these patients, lungs of these patients as well. So don't be surprised if you read about rheumatoid nodules involving like the area between the SA node and the AV node, and in the MCQ it may be written that these patients are having a first degree heart block. Yes, guys, patients of rheumatoid arthritis obviously have obviously have joint involvement, but they can have cardiac involvement also. These rheumatoid nodules can cause both tachyarrhythmias and bradyarrhythmia both, so they can be increased cardiovascular mortality even in these patients. Like I was describing to you that in SLE patient, after a decade of our diagnosis, after 10 years of our diagnosis, the cause of death is increased cardiovascular mortality. Similarly, in these patients also, the leading cause of death is directly, like here, there is nothing like decade, it is spread, increased cardiovascular mortality. SLE, lupus nephritis and cardiovascular mortality. In scleroderma, pulmonary artery hypertension, here it's again CV mortality. Heart blocks can happen. You could have like tachyarrhythmias occurring in these patients. The most common part of the cervical spine involved in rheumatoid arthritis is C1, C2. The question was descriptive. This lady of rheumatoid arthritis, because she's having joint pain now, so somebody told her to do yoga. And while she's doing yoga, she did a headstand. Patients of rheumatoid arthritis should be told, you can do yoga, you can do neck exercises, whatever. Don't put pressure on your cervical spine C1, C2, because you could end up with atlantoaxial dislocation. This case must have come to AIIMS hospital. That is why, like in INICET, they put up this question that a lady diagnosed with rheumatoid arthritis did yoga and she was doing a headstand. Like our coach was telling her to do that neck exercises and then headstand. And after that, doing that headstand, she was not able to sit. She developed paralysis of both her legs and both her arms. Quadriplegia. Guys, patients of rheumatoid arthritis should be explained that you have a very vulnerable joints, including the joints of C1, C2 part of your spinal cord. And God forbid, if you develop a atlantoaxial dislocation, you will be wheelchair bound for whole of your life. You can't use your arms, you can't use your legs. They would be below, like, I mean, C1, C2 gone. So arm paralysis and leg paralysis can happen. Quadriplegia will happen. The most common valvular lesion seen in these patients is MR. Only time aortic valve will come is ankylosing spondylitis. For all rheumatoid lesions by default, Lehmann-Sachs endocarditis, mitral regurgitation, rheumatoid arthritis, mitral regurgitation. Every time they ask you cardiovascular association from the valve perspective, valvular lesion, it is MR. Only in A, ankylosing spondylitis, it is aortic valve that is involved. then these rheumatoid nodules can not only be present in the heart, these rheumatoid nodules can involve the lungs of these patients also. Like I've shown a couple of rheumatoid nodules, they are inflammatory, so these nodules will break down. When these inflammatory nodules will break down, they will be resulting in production of a pleural effusion. So there could be like a pleural effusion described in a question of rheumatoid arthritis, which looks very shocking because we're talking about somebody with a joint involvement. And now suddenly I'm saying this patient is not only having joint issues, but the person can have cardiac issues, person can be having tachy or bradyarrhythmias, or can develop a pleural effusion. And when I will do a thoracocentesis, like I put a needle here in the 8th intercostal space, and I've done a thoracocentesis in this patient, ultrasound guided. When I will check this pleural fluid for estimation, this would be an exudate, so it will satisfy the Lights criteria. The Lights criteria will be, I'm writing it here, though this is discussed in recipe, optional if you want to note down. The pleural fluid LDH values and the pleural fluid, protein values would be elevated. The pleural fluid LDH will be more than 0.6 times the serum LDH, and pleural fluid protein will be more than 0.5 times the serum protein value, because this is exudate, guys. What you are having in this patient is a exudative pleural effusion. And apart from this findings of exudative effusion, he can also ask you regarding what will happen to the sugar here and which crystals would be present. So because it is inflammatory, sugar will be low because the rheumatoid nodules are, it's an autoimmune disorder, man. Autoimmune disorder will consume the sugar, so the sugar values will be low, and in these patients cholesterol crystals can be present. Then one of the drugs, that is like he will say this lady has recently conceived, what drug is not to be used? Then your answer is leflunomide. Obviously it's a category X drug, so we will not be using it in pregnancy. He will say this is a known case of rheumatoid arthritis, she recently conceived, which drug should be stopped immediately? Or she's planning to conceive, what drug should be stopped immediately? Leflunomide. One of the commonest drugs that is written for management of this condition, left, right, center, is tofacitinib. Every rheumatologist, whether ankylosing spondylitis, whether rheumatoid arthritis, सीरो पॉजिटिव सीरो नेगेटिव, सबको टोफासेटिनिब लिख रहे हैं, ब्लैंकेट ट्रीटमेंट दे रहे हैं, देख भी नहीं रहे, because commission, right? The pharma companies are giving big time commission. So wrong prescriptions are being written, guys. People who don't reach that threshold of treatment of tofacitinib are being given it. And the most common lymphoma seen here also is diffuse large B-cell lymphoma. So the risk of lymphomas is increased in most autoimmune disorders. And these autoimmune disorders can even contribute to even vasculitis. In fact, the connective tissue disorder vasculitis is a small vessel venulitis. Yes, veins get involved, venulitis. I'll talk about that when it comes to the vasculitis component. But at the moment, the data that has been shared with you is for RA, that is rheumatoid arthritis. To finish this, I can say, he will say, what is the hematological manifestation of this condition? And you are like, bhai, aur kitna puchega, right? One page is already full. The hematological feature of this would be answered as like, peculiar thing, no? He's asking you joint problem and then saying the hematological feature of rheumatoid arthritis is, then hematological feature is normocytic normochromic anemia, that is anemia of chronic disease. This was like, I would say, a dummy kind of a question just to upset the rhythm, because one is reading about arthritis, so one tends to be like focused on like the joint part only, and here hematological manifestation is given. The next question is from ophthalmology, but still worth. In fact, in this entire discussion, two very peculiar things I've taught you is one, that atlantoaxial dislocation causing paralysis, and second is what I'm telling you at the moment, ocular manifestation of rheumatoid arthritis. जितने भी rheumatoid disorder है ना, सबका ocular manifestation is uveitis except rheumatoid arthritis. Rheumatoid arthritis में क्या आंसर करोगे तो बोलना the rheumatoid manifestation here, the ocular manifestation of this rheumatoid disorder should be answered as keratoconjunctivitis sicca. Yes, guys, this would be answered as keratoconjunctivitis sicca. Why that's important is uveitis and iritis is a manifestation of all of them. In fact, let's do this question. Iritis is seen in all of the following except. So it's seen in ankylosing spondylitis, Behçet's and ulcerative colitis, but not with rheumatoid arthritis. I've already explained to you the manifestation that is seen here is called as keratoconjunctivitis sicca. That's the ocular manifestation. Next, my focus will be on axial spondyloarthropathy, in which there would be involvement of the axial skeleton, that is the spine and the sacroiliac joints can be involved. So difficulty in bending forward can be present. Sacroiliitis will cause a bamboo spine, and like HLA-B27 conditions will be discussed here, including the mnemonic pair. Pair would stand for psoriatic arthritis, where you get sausage digits. Then is going to be ankylosing spondylitis, which will be discussed subsequently. Then is inflammatory bowel disease, more common with ulcerative colitis. And then is reactive arthritis, also called as Ritter syndrome. The details of Ritter I will add in the later part of the discussion, but pair is a mnemonic to be remembered for HLA-B27 positivity. Psoriatic arthritis, ankylosing spondylitis, inflammatory bowel disease, and reactive arthritis. For the ankylosing spondylitis part, one, like they can give you this test which is called as Schober's test. It will be a simple thing that will be demonstrated where the person is being asked to bend forward. We put markings on the back. Even if you don't remember these markings, I just want to say that in a normal person, when you will bend forwards, then the gap between the 2 points which are put on the skin, these markings that are done, the gap between them should increase. But if a person is having restricted spine mobility, then this gap will not increase. So the test that we do is called as Schober's test. It's done for ankylosing spondylitis, and it is also done for one more condition called as alkaptonuria, which can cause osteoarthritis of the spine. So Schober's test or modified Schober's test, I mean, he might not write the word Schober, he may write the word modified Schober's test. One is done for patients of ankylosing spondylitis, but you can have a degenerative spine disease even in this disorder where there's a homogentasic acid oxidase deficiency, that is by the name of alkaptonuria. Normally we read about that ochronosis of the pinna, but I'm saying osteoarthritis of the spine can be present. In this particular case, the X-ray finding would be that of bamboo spine. These patients have a rigid osteoporotic spine that can fracture. I mean, one of the reasons why these patients can die is a rigid osteoporotic spine can fracture. So paralysis of the patient will occur. Instead of writing the word bamboo spine because of the osteophytes, he may even write the word dagger sign. Now, the cytokines which are involved in this condition are one, tumor necrosis factor alpha, and the second one is by the name of IL-17. So subsequently I'll discuss with you a drug which can neutralize IL-17. This would usually be a young male with a low back pain. Usually the joint that is involved in this condition is the sacroiliac joint. So he will not begin by saying the word sacroiliitis, because if the examiner himself will say, it will become very easy. So he will talk about a male patient. He will say that he's having morning stiffness, and then will be a very characteristic feature that he gets out of the bed, he starts moving around, then the pain tends to improve with exercise, not with rest. Like he says, if he's lying in the bed, the pain does not go away. But he says, when I put my foot on the ground, I start walking, then I feel relatively better. A lot of these patients can be having alternative buttock pain and reduced spinal mobility. And over a period of time, over the next 1 decade, the person will be having loss of lumbar lordosis, and therefore the height of the person, like this person might become like, the body might become slightly bent forward, and the overall height of the patient might be lost. It started off as a young guy, back pain, night pain also present most of the time, taking painkillers. And then description of alternating buttock pain, restricted spine mobility makes it easier for us to understand the disease process. This is just to increase the length of the question, especially like in FMG exam, he'll not straight away come to the point and say sacroiliitis. He'll try to describe the findings that I've described. Then when you do examination of the patient, the chest expansion will be reduced. That's because of the costochondritis component. So the disease not only like costochondral stiffness, this condition causes a extraparenchymal restrictive disease in a sense that the costochondral joint stiffness is the joint involved is sacroiliac, it is okay, but because I was saying involvement of the axial skeleton, so even the costochondral joint stiffness can be present. That is why chest expansion would be less. That is why these people cannot be recruited into the forces, because physical capacity would be limited. Modified Schober's test is positive, and then occiput to wall distance will again be reduced because neck mobility is again restricted. The main test that is done in this patient is MRI of the sacroiliac joints. Don't answer X-ray, because X-ray findings will take some time to appear, and the earliest finding to appear, that is the main point which I wanted to highlight. The earliest finding he wants to hear is this word, bone marrow edema. This is one of the early manifestations that is seen in ankylosing spondylitis, and subsequently, like you'll have that classical joint restriction and sacroiliitis occurring. The question will like describe all these findings himself. Costochondritis will not ask you the diagnosis. He will himself say HLA-B27 positivity is also there. HLA-B27 is less accurate a test for diagnosis because it can be present in multiple other conditions of pair. So between the two, HLA-B27 positivity and MRI, like MRI is much more superior as compared to this test that I have mentioned. Now, As far as in the question, he may not mention the word HLA-B27 positivity, may not be present sometimes also. It may be bone marrow edema that has to be picked up, reduced chest expansion that has to be picked up, modified Schober's test that has to be picked up. Those are the words to be remembered. And then he will say, what is first line treatment? Your answer is simple, NSAIDs. Subsequently, obviously, I can put the patient on tofacitinib to alter the disease process. Then the anti-interleukin 17 molecule, because one of the cytokine there was one was tumor necrosis factor alpha, so I can use infliximab for that. I mean, if you ask me what is that anti-tumor necrosis factor alpha antagonist, then tumor necrosis factor alpha antagonist is infliximab. But if he says what is the molecule that you are going to use against interleukin 17, then it is secukinumab. Secukinumab and monoclonal antibodies are in thing nowadays, so they love to ask about it. Infliximab and secukinumab. Then most common extra-articular manifestation of ankylosing spondylitis is iritis. That would be the uveitis component. The disease can involve the lungs also, like in rheumatoid arthritis, lungs can be involved. Here also, lung involvement can lead to pulmonary fibrosis. The commonest cardiovascular association seen here is aortic regurgitation. This is different because in all others it is by default mitral regurgitation. I've told you only for ankylosing spondylitis it is aortic regurgitation, and the extra-articular feature of rheumatoid arthritis I've already explained to you. If he says what is the commonest extra-articular manifestation of rheumatoid arthritis, it is rheumatoid nodules. And I hope I've been able to explain to you that these nodules can be present in the skin. The nodules can be involving the lungs and they can break down to form exudative pleural effusion. The rheumatoid nodules can be involving the heart, so they can be both tachyarrhythmias as well as bradyarrhythmias in a patient. The causes for HLA-B27 positivity have already been discussed. The reason why they discussed again is because I wanted to introduce reactive arthritis. He will mostly talk about sex tourism. He will say this is a businessman. He went to Bangkok. He had unprotected sexual exposure with a sex worker. And when he came back, he could not go back to his house because, not that he's ashamed, because he's having exposure to chlamydia and then he's having urethritis. He cannot pee, urethritis, like this burning micturition. He cannot see properly because there's a uveitis and a conjunctivitis. So there would be a red eyes occurring in this patient. There is a uveitis and a conjunctivitis, so can't see, and he can't walk because of the pain in the knee joints, that is arthritis. So can't see, can't pee, and can't walk are features of reactive arthritis, which most of the time would be seen in like a businessman back from a sex tourism visit abroad, and now he's having these manifestations. Then he will also ask you about the skin manifestation of this patient, which will be seen on the soles of the foot of this patient. I'll show you the image of this horrible looking lesions on the soles of the foot. If they ever give you rash on the soles of the foot, either it's going to be a presentation of syphilis. Syphilis always causes a rash that can occur in the palms and the soles, or it would be the manifestation that I've currently written before you, which is an image-based question where you see these brown macules on the skin. This is what is called as papules on the skin, that is called as keratoderma blenoragicum. I'll just write the name once again. The lesion that I've currently shown here before you is what is called as keratoderma blenoragicum. This would be brownish papules on the sole of the foot. This is an image-based spotter that you have to pick up in this guy who came back from sex tourism. And it is not necessarily always chlamydia as a reason, though I was describing it initially from a sex tourism perspective. It can be post dysentery in a patient. It could be sepsis in a patient, again UTI, that is like urea plasma urelyticum, and the lesions of keratoderma blenoragicum is what I wanted to highlight. Then is a quick short MCQ on Sappho syndrome, where the P part is not like psoriasis, it is pustulosis that is to be remembered. Synovitis, acne, hyperostosis, osteitis. He put up psoriasis there, it is pustulosis. So next we come to the topic of vasculitis. First you need to remember this setup of large, medium, small and variable vessel. For large vessel vasculitis, the first example to be remembered is giant cell arteritis, which would be involving the superficial temporal artery. So the classical feature will be jaw claudication, and second would be that vision loss that can be seen due to ischemic optic neuropathy. The second one is Takayasu's arteritis, which is also called as pulseless disease. This disease has a speciality of involving the blood vessels that originate from the arch of the aorta, and this was asked in FMG exam, which is the most common blood vessel involved here. Your answer is left subclavian artery. So two names I've said, I've not written them. Superficial temporal artery for giant cell arteritis, and left subclavian artery, or left and right subclavian artery, left to be precise, for Takayasu. For medium vessel, there are two entries to be remembered. One is polyarteritis nodosa. One question covered right now, polyarteritis nodosa में pulmonary artery is not involved. PAN, polyarteritis nodosa, PAN, pulmonary artery is not involved. Pulmonary artery is not involved. The second one is what I'll describe for a child, which is called as Kawasaki disease. The manifestations of this would be discussed when the time comes, but we have to use like intravenous immunoglobulins in these patients. And if there is like those giant aneurysms in the coronary arteries present, then we might have to give aspirin in these patients lifelong. Yes, guys, this is again an FMG exam question, that aspirin to be given for Kawasaki for 6 weeks, 8 weeks, 3 months, lifelong, lifelong. Normally, you read about lifelong aspirin in heart disease patients in adults, but for a child, lifelong aspirin, guys, that is with giant coronary artery aneurysm. So I'll describe that angiography report to you as well. But that question has to be remembered right now, that pulmonary artery is not involved in polyarteritis nodosa, and lifelong aspirin, obviously low dose, lifelong low dose aspirin is to be taken for a child with Kawasaki disease because of giant coronary artery aneurysms. Then comes the aspect of small vessel vasculitis, where which blood vessels would be involved. So it is not the arterioles, it is the post capillary venules that are involved, which can be associated with ANCA. The diseases which are present here are formerly called as Wegener's granulomatosis, now called as granulomatosis with angiitis. Then is Churg-Strauss disease. Churg-Strauss disease is now called as eosinophilic granulomatosis with polyangiitis. One of the highlights of Churg-Strauss disease would be association with asthma and peripheral blood eosinophilia, that I'll be filling up the details subsequently. Then is microscopic polyangiitis. Then is immune complex mediated small vessel vasculitis, that is Goodpasture syndrome. Goodpasture syndrome will always be having a combination of hematuria, and along with this there would be hemoptysis. That would be easy to pick up because he'll also talk about anti-basement membrane antibodies present here, and this is an example of type 2 hypersensitivity. Henoch-Collin purpura is a vasculitis that is found in children, one of the commonest vasculitis, and the highlight of this is, one, it is immunoglobulin A mediated, and the MCQ will always say the word palpebral extensor purpura. I'll show you the image of this also, but I'm giving you a heads up into a couple of questions which are like very easy to pick up. The moment you read the word palpebral extensor purpura, or if you read about giant coronary artery aneurysms, then you know it's Kawasaki disease and palpebral extensor purpura for Henoch-Collin purpura. Cryogenic vasculitis is a extrahepatic manifestation that is seen with hepatitis C. And when it comes to variable vessel involvement, then it is Behçet's and Kogan. Both of them will be discussed when the time comes. But I've done some filling up of some important questions at the moment. And for giant cell arteritis, like I've not written, but I'll do that subsequently. That is the superficial temporal artery and the left subclavian artery getting involved. Then another statement that I had made verbally earlier, but I'm highlighting at the moment, all connective tissue disorders, SLE, scleroderma, can cause involvement of small vessels. What is involved is the venules. It is the venules, venulitis that would be found. I mean, vasculitis part in rheumatic disorders can be like with SLE and scleroderma, you could have a small vessel vasculitis. Then is pathology data, granulomatous vasculitis. Lot of G's there. Granulomatosis, like giant cell. I mean, G, the word itself is there. Giant cell arteritis, but this is a granulomatous vasculitis where superficial temporal artery is involved. Then is granulomatosis with polyangiitis. Here, I don't think so. It would cause any like difficulty in remembering because the name is like this only. Granulomatosis with polyangiitis, and this condition was formerly called as Wegener's granulomatosis. In this condition, there will always be a triad that will be given. In the triad, two features will be common with what is described for even Goodpasture syndrome, that is hemoptysis and hematuria. But the third feature that will be given in this question would be that of epistaxis. You see, Wegener's granulomatosis is a disorder in which there is vasculitis of the upper respiratory tract, so you get epistaxis. You get vasculitis of the lower respiratory tract, so you get a hemoptysis, and you get vasculitis of the kidney, so therefore there's a hematuria. So GPA, granulomatous with polyangiitis, causes these three manifestations together, whereas in Goodpasture it is only two of them. And if you are still in doubt, then granulomatosis with polyangiitis MCQ C-ANCA antibody will always be given. I mean, by default, if C-ANCA is given, even if you don't remember the remaining features, you would still know that you're dealing with granulomatosis with polyangiitis, which is formerly called as Wegener's. They will not ask you that rare thing of strawberry gingiva. Yeah, you get strawberry gingiva in this condition also, but they'll ask you the combination of epistaxis, hemoptysis, and hematuria, whereas combo of hemoptysis and hematuria is Goodpasture syndrome. Then is eosinophilic granulomatosis with polyangiitis. So if you look at it right here, the word is giant cell arteritis, but it is associated with granulomas. Then is granulomatosis with polyangiitis. Then is eosinophilic granulomatosis with polyangiitis. That eosinophilic word I highlight peripheral blood eosinophilia and asthma association is usually seen in these patients. And the fourth entry for the granulomatous like vasculitis, that these are the GGG words here. Now there is no G alphabet here. The fourth entry for granulomatous vasculitis is Takayasu's arteritis. So what I've covered here is a pathology question. They'll jumble up the data. Granulomatous vasculitis is seen in all except. Usually the fourth option would be like microscopic polyangiitis, in which it's a necrotizing vasculitis that is present. But at the moment that G alphabet makes life a little easier to remember, like granulomatous. But yeah, obviously for GCA, it is like a giant cell granulomatous vasculitis. So I just wanted to clarify that. And fourth entry is Takayasu's arteritis. And like in all except MCQ, it will be microscopic polyangiitis. Next up is Cogan syndrome, which is for variable vasculitis. How to remember this is Cogan, CO is for cornea involvement. That is that non-specific interstitial keratitis. And that gun is like, I can say Cogan ka Gana, right? Gana is like related to ear, no? I mean, when I say the word Gana, Gana in Hindi is for songs. Songs is what you hear with your ears. So you can be having ear problems in these patients. That is audio vestibular complaints, which could be ranging from tinnitus, vertigo, etc. So only one possibility can be that somebody can mistake this question to be that of Meniere's disease, where dizziness, vertigo, tinnitus, etc. will be given. But in this question, apart from dizziness, vertigo, tinnitus, additional features would be that of interstitial keratitis, that is Cogan syndrome. Another fact which is covered in ophthalmology, but I'm still mentioning it here, is Vogart-Koyanagi-Harada. In Vogart-Koyanagi-Harada, you get eye involvement, you get ear involvement, plus additionally you get a skin involvement in the form of vitiligo and the sinus involvement in the form of aseptic meningitis. I'll repeat the features once again for the eye and the ear involvement that is seen in Cogan versus eye, ear, skin and the sinus involvement of Vogart-Koyanagi-Harada syndrome. I'll also try to introduce one more example which will make it easier for you. Like, you are all aware of that condition now where eyes are defective, ears are defective, heart is defective, PDA. PDA associated with congenital rubella syndrome. In congenital rubella syndrome, you read about eyes being defective, cataract. You read about ears being defective, sensory neural hearing loss, and you read heart being defective, PDA. So just like you are comfortable with the fact that like congenital rubella syndrome, eyes, ear, and heart can be defective. Today, I want you to remember Cogan is eye and ear involvement, that is like cornea involvement, CO, that would be interstitial keratitis, and Gana for ear, that is like audio vestibular symptoms, which can be like written the way they are written. They may look like Meniere's disease presentation, but add keratitis, everything changes. And if it is eye, ear with CNS and skin involvement with vitiligo and aseptic meningitis, then it is Vogart-Koyanagi-Harada. As far as the commonest type of vasculitis in adults is concerned, then your answer is not giant cell arteritis, it is idiopathic. Yes, guys, the most common cause of vasculitis in adults is not gonna be answered as giant cell arteritis. It is idiopathic cutaneous vasculitis. If he says this, what is the most common cause of vasculitis in children? Then it is Kawasaki disease. Yes, it can be Henoch-Schönlein purpura also, but then overall, like if he says in Indian children, because in India, what is relatively more common is Kawasaki disease. On a global basis, like I agree to the fact that it would be like Henoch-Schönlein purpura, and most of the time nowadays they give like supportive evidence also. Like if they wanna give you a coronary angiogram, and along in this coronary angiogram, you can notice those big aneurysms which are present in the left coronary artery of a patient. So considering coronary artery CA means coronary artery vasculitis is given in this question, you will say that you're dealing with Kawasaki disease. But suppose it gives you a question in which on the buttocks of the patient, backside of the thighs of the patient, backside of the legs of the patient, like in this image, you can notice that very classical extensor purpura present. Then you will say that you are dealing with Henoch-Schönlein purpura. For Henoch-Schönlein purpura, more technical details will be told in the subsequent slides. Let's practice giant cell arteritis. They'll give you a slide. The highlight will be that the blue infiltration will be present in all the layers of the slide. Tunica intima, tunica media, tunica adventitia, all are totally affected to the level that the lumen of the blood vessel will be totally gone or totally obliterated. In fact, in this condition, there is like a fragmentation of the internal elastic lamina. That's an important feature to be remembered from the pathology perspective. We get giant cells present in these patients and they cause fragmentation of internal elastic lamina, which gives a lot of structural support to the wall of the blood vessel. The type of vasculitis seen here is called as granulomatous vasculitis that begins with G, and there are giant cells also present, which are present mainly in the area of the tunica, present in the area of the internal elastic lamina. The disease will start off as narrowing of the superficial temporal artery, and because the lumen of the blood vessel will be progressively become narrow, so in this lady what will be happening is complaint of headache. Like a non-medical person will not be able to perceive where the pain is coming from. A lot of these questions will begin by saying that the patient is having a temporal headache. It is an extracranial cause of headache. Guys, normally whenever we read about headache, it's always an intracranial cause, no? Migraine, brain tumor, they're all like intracranial cause, cluster headache, they're all intracranial causes. But in this condition, there is a superficial temporal artery which is narrowed, and therefore there is ischemia of the skin of the scalp. There is ischemia of the skin of the scalp because the superficial temporal artery, you can palpate your artery at the temporomandibular joint, it supplies the skin of the scalp. So ischemia of the skin of the scalp and the superficial temporal artery luminal narrowing is the reason for development of headache in these patients. And a lot of these patients, what they are saying as a headache is actually the burning sensation on the side of the skin. They will even press on the skin to say that it hurts. It's actually that ischemia pain. It's like the pain of the ischemic nerves, that is scalp tenderness would be described. Then whenever she's eating, then there would be jaw claudication that would be present. That's again a very classical statement, jaw claudication. We don't read it anywhere else except for this topic. It would be a senior citizen, or at least if not more than 65, will be more than 50. And a lot of these patients are having a polymyalgia rheumatica association. That again is a question, that which of the following vasculitis is mainly associated with polymyalgia rheumatica, which would be having that non-specific joint pain present. I mean, this lady is complaining of pain in the shoulder, pain in the elbow every time she wakes up in the morning. So even in this question, you might mention about that morning stiffness, but the morning stiffness will be for the shoulders. Like the question might mention morning stiffness, but this time the morning stiffness is not for the small joints of the hand. He might mention this would be a distraction, right? But the morning stiffness would be described for like the shoulders and in the arms of the patient. And then ESR is elevated. I can say that ESR is a diagnostic test in whole of our medical science. It's always a prognostic test in whole of our medical science. The only time it is used as a diagnostic criteria, I mean, you would have never read about like ESR being used as a diagnostic criteria. It is always a prognostic criteria. This is the first time that I'm saying that this would be written as a diagnostic criteria in the question. So if you read a question more than 50 years of age with a woman having headache, which may be written as scalp tenderness and jaw claudication, then you have to think in terms of giant cell arteritis. A lot of these patients can be having low-grade fever off and on also. So fever of unknown origin or low-grade fever can be present as an initial presentation of these patients. When we'll do workup, obviously we'll think it could be low-grade fever due to TB or due to like autoimmunity, but the autoimmune panel and the infection panel in the patient will turn out to be negative. This is low-grade fever. Then is scalp tenderness, jaw claudication, and the bad news is she can go blind. One of the, like, I would say unfortunate complications in this patient can be ophthalmic artery involvement, which can contribute to possibly blindness in these patients also, that they love to ask. Therefore, because the risk is so high, we will not be doing a biopsy straight away of the blood vessel. We will first start steroids because the preservation of vision is of paramount importance. And then we can do a biopsy, and biopsy will be curative in a sense also, that it will damage the nerve ending. So the perception of pain in the patient will also be reduced. In fact, on the basis of this discussion of SCOPE, that is SCOPE, which I'll highlight here, scalp tenderness, claudication of the jaw, old age patient, polymyalgia rheumatica association, ESR being included in a diagnostic criteria. And if he himself says giant cells present, and he gives this image where all the layer of the blood vessels are infiltrated and the lumen is completely obliterated, you can see the lumen is hardly visible, man. Like there's a severe luminal narrowing present, which tells us regarding the presentation of this disease. Which of the following is not seen in patients of small vessel vasculitis? So what you will not get is a visual loss. You can understand that visual loss is a feature that is seen with giant cell arteritis, right? The visual loss manifestation is with giant cell arteritis. Otherwise, like hemoptysis, hematuria, they were seen with those associations with the C and Kana, like Wegener's granulomatosis, that was small vessel vasculitis, palpable purpura, and oxcolin purpura. So the point is, like visual loss is seen with giant cell arteritis, which is an example of large vessel vasculitis. Then he gave a question very smartly created. Lady was having headache over the frontal area, and when the question mentioned female with headache, a lot of people thought that this again is a question of giant cell arteritis, but it is a young lady. The headache is not temporal headache. In this particular case, guys, the headache which is present would always be described as, in fact, I would like to clarify this here. Good that I went through this question. This is a PYQ that I mentioned. The question of giant cell arteritis will always mention the word temporal headache, temporal headache. Whereas the one that I'm at the moment describing before you is a frontal headache. That means there is sinusitis. Now, if you ever had sinusitis in your life, maxillary or frontal, it hurts, bend forward, it hurts. So positional change is just a distraction. It's a sinusitis, which is like the headache worsening with position change that is being mentioned. Then is mentioned blood in the sputum, that is hemoptysis. The workup also shows RBC casts. So there is a hematuria and there's a positive ANCA. I have already sensitized you to the fact that if you get a hemoptysis, hematuria, ANCA positivity, it's a vasculitis that is being talked about, and the vasculitis can involve the upper respiratory tract. So it may not begin with saying epistaxis. Like in this question, deliberately he did not mention epistaxis, he mentioned sinusitis in a patient, but it is vasculitis of the upper respiratory tract causing this manifestation. So therefore the triad that I was describing, that epistaxis word is not there, but vasculitis of the upper respiratory tract is there. So I hope you were able to figure out that the answer to this question is granulomatosis with polyangiitis, not Goodpasture syndrome, because Goodpasture will be having anti-basement membrane antibody. That is why I am ruling it out. Microscopic polyangiitis is associated with P-ANCA. The antibody present with Goodpasture is anti-basement membrane antibody. With microscopic polyangiitis, the antibody associated is P-ANCA. And for henoxcolin purpura, then the presentation would be of that extensor purpura on the buttocks and the back of the thigh, and would not be the manifestations here. So this was a well-crafted question that came, where the question was about a woman with a headache. So a lot of guys casually answered it as, though in this question, like there's no mention of giant cell arteritis, a lot of guys were like, sir, I think this was GCA kind of a presentation. I could not figure out the answer. Why he is not giving temporal headache? He's not giving that jaw claudication. And lots of time in giant cell arteritis, like they will show that image, where the artery is very big and visible on the scalp. Sir, in reality, most of the time, that kind of a presentation is only in textbooks. Initially, that tortuous course of the blood vessel may not be visible. That is a very late presentation that they try to show, that, oh, check out the blood vessel, it is giant cell arteritis here. That is like, I would say, that's like fiction, right? In reality, it is like the early presentation is what I currently explained to you. So don't rely on that image of that blood vessel on the scalp would be given and only then I'll answer it as giant cell arteritis. There are things beyond that also, and ischemic optic neuritis is one big risk factor present in these patients. The last question on this slide is like a well crafted question that you need to understand. Now I'll focus on a topic where the moment you see the angiogram, you can see that in the renal artery, there are small aneurysms that are present. Multiple areas in the renal artery. Even when the renal artery has divided into branches, you can see the kidney and you can see the chota aneurysms which are present here. So considering the manifestation of these small aneurysms, not one, but multiple. And along with this, renal artery getting involved and the skin involvement that is shown here, which is in the form of livedo reticularis. If I write down the manifestations here, let me just highlight them here. The fishnet appearance. The question is describing that the patient is having livedo reticularis. This is going to be a fishnet appearance of the blood vessels in the skin. Usually we read about fishnet appearance with respect to that pemphigus vulgaris, that skin biopsy. But today I'm teaching a fishnet appearance of livedo reticularis and multiple chota aneurysms in the renal artery of the patient. So the disease that I'm pointing to at the moment, guys, is polyarteritis nodosa. Yes, polyarteritis nodosa causes this peculiar involvement of small aneurysms in medium to small blood vessels. That's why the literature will say medium vessel necrotizing vasculitis. Let's write the name here. The name of the disorder is PAN, polyarteritis nodosa. When I say that polyarteritis nodosa, I also want to say that it ends with the N, and the moment it ends with the N, it should remember it's a necrotizing vasculitis. Prior to this, I was describing to you a disorder where I was using the phrase or the word that the patient is having granulomatous vasculitis. Now I'm saying the word necrotizing vasculitis, that is polyarteritis nodosa. Muscular arteries are involved with microaneurysms in a segmental fashion. A couple of these patients can be associated with hepatitis B. You can have hematuria, but there is no glomerulonephritis. I will say two questions in a negative sense. In this condition, pulmonary artery is not involved. I explained that right in the beginning also. Polyarteritis nodosa, PAN, pulmonary artery not involved, and you don't get a glomerulonephritis, but you still get a hematuria. The question will begin by describing a hypertensive patient, and then we'll say that because there is a vasculitis involving microaneurysm formation involving the small blood vessels of the fingers, so there would be a combo of hypertension with digital gangrene. You will not see this anywhere else. Even if you forget everything about this topic, this is a must know. Then kidney involvement will cause hematuria, but without glomerulonephritis. Traditionally, we read about hematuria with glomerulonephritis, but this time, like it's direct damage to the blood vessels, there's no damage to the glomerulus. Then the blood supply of the intestine can be damaged, mesenteric artery damage, so abdominal pain. They can be damage to the blood supply of the coronary arteries, like mesenteric arteries are damaged, so abdominal pain. Coronary arteries are involved, so chest pain. Cerebral arteries can be involved, so stroke manifestations can be occurring in a patient. This can contribute to development of ischemic stroke also. I mean, PAN is a multi-system disorder. It affects small to medium blood vessels. It can affect coronary circulation. It can be affecting cerebral circulation. Coronary artery circulation will explain chest pain. Cerebral involvement in these patients will explain the ischemic stroke kind of a presentation. And then comes nerve involvement, that is mononeuritis multiplex. This is peculiar. You will read about mononeuritis multiplex 2 times in this discussion, one with polyarteritis nodosa and second with respect to that Churg-Strauss syndrome, where I'll introduce this again. In fact, at this moment, I want to say that even the nerve supply of multiple nerves is getting affected. So you could be having carpal tunnel syndrome with tarsal tunnel syndrome. You could be having carpal tunnel with meningia paresthetica. Why? Because multiple individual nerve blood supply is getting affected. Two disorders where you will read about mononeuritis multiplex will be, one is what I'll describe in Churg-Strauss syndrome subsequently, and the second is the topic of interest, polyarteritis nodosa. The most common cause of mononeuritis multiplex, however, in India is leprosy. Hansen's disease is what will be written. I've told you 3 causes for mononeuritis multiplex. Just like in a multiplex, multiple movies run together. Here, same patient could be having multiple peripheral nerve involvement. So leprosy, Churg-Strauss syndrome, and polyarteritis nodosa can have this presentation. And the skin lesions is that fishnet appearance that I showed before you. That fishnet appearance with that irregular appearance of veins on the skin. This is called as livedo reticularis. So these are features of polyarteritis nodosa, where 20% cases can be associated with hepatitis B. Now I want to show a renal angiogram to you in which a very beaded appearance, like a string of bead appearance is present. I mean, here the appearance that is present is more like granular. Instead of aneurysm formation, it's like a granular appearance that is present. So this is a feature which can cause like renal artery stenosis, and it can contribute to renovascular hypertension. This is a rare cause of renal artery stenosis. It is called as fibromuscular dysplasia. This was a radiology/medicine based question, spot diagnosis in FMG exam, so I thought I should mention it. This is in contrast to, like in a different session in the exam where they gave this renal angiogram where multiple like small aneurysms could be seen. So then we will say polyarteritis nodosa, whereas if this is the presentation, then we will say renal artery stenosis. Needless to say that renal artery stenosis cannot occur with PAN. PAN causes aneurysm formation, so stenosis will not happen. It is fibromuscular dysplasia. And then the next one is causing like narrowing at the starting of the renal artery, especially on one side. Like, let me show this one. Other side renal artery is okay for comparison. This renal artery is narrowed. So one of the reasons why this can happen is ARAS, that is atherosclerotic narrowing. This is atherosclerotic renal artery stenosis that is developing. Overall, if I say to you what is the most common cause of renal artery stenosis, then it is atherosclerotic renal artery stenosis, which is written as ARAS. The drug of choice for hypertension in renal artery stenosis should be answered as ACE inhibitors, but they are like contraindicated in bilateral renal artery stenosis. So if he specifically says what will you do for bilateral renal artery stenosis, then don't answer ACE inhibitors, they're contraindicated. ACE inhibitors are absolutely contraindicated in bilateral renal artery stenosis. So if he says what is the treatment that would be done for management of patients of bilateral renal artery stenosis, giving you few seconds to think about it. Yes guys, how do you handle bilateral renal, because BP बहुत ज़्यादा होगा ना. I will use calcium channel blocker, but BP will not get controlled with it. So what I might have to do in this patient is a percutaneous transluminal renal angioplasty. We'll do a balloon angioplasty, and after doing a balloon angioplasty, we can be doing stenting in these patients also. So ACE inhibitors can be used, calcium channel blockers can be used in these patients if required. But then in bilateral renal artery stenosis, if he says treatment of choice, if he says the word, what is the treat? I can obviously use calcium channel blocker or even prazosin, but there's a limit to the amount of like calcium channel blocker or prazosin I can use. So then I'll be saying like I can go for PETRA, percutaneous transluminal renal angioplasty with stenting. Now I will describe before you a case of Silk Road disease. This patient is on medical tourism, and when this patient came, her complaint was all through her mouth. She's having crops of aphthous ulcers all through the oral cavity, like she's having these painful lesions that heal without scarring. The important statement is there is no scarring, they heal without scarring, but there is crops of ulcers in the oral cavity of this lady. She has come from Syria or like Egypt, like Arab patient on medical tourism for India, and complaints are aphthous ulcers, crops of aphthous ulcers in the mouth. Then this lady is also telling you that the ulcers are also present on the genitals, that is on the vulva. And in a male patient, they are not on the glans penis, guys. That is important. In patients of Behçet's disease, you will be noticing that in a male patient, if aphthous ulcers are there, then the ulcers would be on the scrotum, because normally we read about ulcers on the penis, no? That is like sexually transmitted disorder. But this is not an STD. This is a vasculitis that can cause a scrotal ulcer in a patient. Again, very peculiar statement, scrotal ulcer in a patient. The oral ulcers heal without healing. Even genital ulcers heal, but they come back. And then when you look at the eyes of the patient, they're bloodshot red because there's a panuveitis or there's a hypopion present. So how to remember this manifestation is the phrase that I'll say. The phrase to be remembered is oro-oculogenital syndrome. Yes guys, oro-oculogenital syndrome is a hack to remember Behçet's disease. The oro manifestation is aphthous ulcers around the ear, in the mouth of the patient. She showed her doctors in Egypt, did not improve, came to India. 2 years she has been suffering. Then she's having involvement of the genitals, which I've explained. The lesions are present on the vulva or on the scrotum. And when you look at the eyes of this patient, there is like pus in the anterior chamber of the eye. There is a hypopion. So oro-oculogenital syndrome is Behçet's disease. If he writes HLA-B51, then your job is sorted, right? But lots of time he will not write the word HLA-B51. Then you have to rely on the words. Try to do with me. Oro, that would mean aphthous ulcers. Oculo also means, genitals also mean aphthous ulcers. And the oculo is going to be pus in the anterior chamber of the eye along with uveitis. So the combo of the three is what is called as Behçet's disease. And one of the tests that is used to identify this condition, one of the tests that helps in diagnosis of this condition is called as Petherji test. Petherji test is an example of type 4 hypersensitivity reaction. You will use a hypodermic needle and you might inject saline into the skin of the patient. You're just using hypodermic needle and pricking on the skin of the patient, and there would be a development of sterile pustule after 48 hours. Guys, don't mix it with that lepromine test or like Mantoux test, where you inject a purified protein derivative. I said you're just pricking with the needle, with the hypodermic needle in the forearm, and just injecting a bit of saline, and there's a big sterile pustule that is developing in this patient. So Petherji test is helpful in diagnosis. It is not like the absolute diagnostic criteria for this condition, but yeah, Petherji test is useful for diagnosis of Behçet's disease. The diagnosis is based on combination of oro-oculogenital, with the main feature being, I'll highlight the main feature, that is these oral ulcers. These oral aphthous ulcers, which are going to be painful, heal without scarring, are like the main feature. Along with this, genital ulcers are present. Then is like the eye manifestations, which help in nailing down the diagnosis of Behçet's disease. For Takayasu's arteritis, they'll always give you a like a MRA or a CTA. And in a MRA, you will always notice narrowing. The narrowing, if you compare the two sides, is of the subclavian artery. So the most common blood vessel involved in Takayasu's arteritis should be remembered always as the left subclavian artery of the patient. This is the commonest one to be involved. Then the manifestations would be, because artery is narrowed, they would be arm claudication. Person will be like, when you raise arms above the level of the head, that's when the pain would be coming. Like patient has to put clothes over a wire, that's when the pain would be coming. Then because it's a connected tissue disorder, fever, fatigue, night sweats, weight loss would be described. And then he will himself say weak peripheral pulses, weak radial artery, radial delay. I mean, one of the main features in this patient is that radial artery pulsations will become weak. I'm not saying that there is a gangrene occurring in a patient. I'm just saying radial artery pulsations of the patient are weak, or on left and the right hand side, they're not symmetrical. That is why it is called as pulseless disease, and therefore the blood pressure difference between two arms would be like substantially present, because subclavian artery is narrowed. So you could also be getting a bruit over the carotid arteries. The investigation of choice I've already highlighted, and because it's a vasculitis, so we shall be using steroids. The main highlight is vascular claudication is a presentation of Takayasu's arteritis, also called as pulseless disease. The question will always mention radial delay, or might mention the fact that like the blood pressure between the left arm and the right arm is unequal in this patient. Then for ANCA-associated vasculitis, though I've given you a heads up already, like the old term is Churg-Strauss syndrome, but now they don't use the word Churg-Strauss. They use eosinophilic granulomatosis with polyangiitis. The moment they say the word eosinophilic, what should click in your mind is immediately that eosinophilia is associated with asthma. So we can use the vowels here, that is AEIOU. There is asthma, there is a peripheral blood eosinophilia that will always be described in this question. In none of the other ANCA, small vessel vasculitis, will you read about peripheral blood eosinophilia. When you check out the X-ray of this patient, you can notice some white spots present, that is transient pulmonary infiltrates. Though you will read about transient pulmonary infiltrates in Loeffler syndrome also, but this is gonna be like associated with asthma. And then there is mononeuritis multiplex. Already told you mononeuritis multiplex 2 times in vasculitis. Obviously Hansen's is there, but then I told it with the like Churg-Strauss, and I also mentioned it earlier also. I'll just show that slide also for like the association for, mononeuritis multiplex, where multiple peripheral nerves can be involved, that is with polyarteritis nodosa. Now coming back to the agenda, guys, the superior diagram that I've shown here before you shows a strawberry gingiva. This strawberry gingiva is a feature that is seen with Wegener's granulomatosis. Nowadays we don't use the word Wegener's granulomatosis, we use the word granulomatosis with polyangiitis. Both of them are examples of granulomatous vasculitis. Mononeuritis multiplex aspect I've already explained, that is multiple peripheral nerve involvement. Now comes the aspect of microscopic polyangiitis, where he will always mention this antibody by the name of P-ANCA. In fact, just like you are comfortable with the fact that C-ANCA, if it is written, it is GPA. Similarly, P-ANCA is associated with both of them, Churg-Strauss and MPA, but is having a higher association with microscopic polyangiitis. He has also asked in pathology that this cytoplasmic antinuclear cytoplasmic antigen, the C part, acts against which target antigen. So your answer is PR3, that is proteinase 3. The target antigen is proteinase 3, and for like the P-ANCA, the target antigen is MPO, that is called as myeloperoxidase. So some of the information that I'm saying will be having overlap from pathology as well. This is the antigen related to against which the antibody is directed. Now the quick comparison between GPA, EGPA and MPA is as follows. GPA hardcore topic from general medicine perspective for NEET PG. If you are an FMG student, you don't need to remember this table. You can listen to me. Yeah, I want you to listen to me once, but you don't need to remember it. But for NEET PG, you have to remember this table. GPA is formerly called as Wegener's granulomatosis. How to remember this? You can remember it simply by the fact that there is a vasculitis that is involving the upper respiratory tract, lower respiratory tract, and also the kidney. Now let's work out the data. As I have explained to you, the vasculitis is involving the upper respiratory tract. So one possibility is that he may mention regarding recurrent sinusitis, like I did in one question, or he might mention about epistaxis, or he can mention regarding saddle nose. Lot of these questions of granulomatosis with polyangiitis will be describing how upper respiratory tract vasculitis destruction is happening, blood vessels are getting destroyed. So sinusitis then would be presentation of epistaxis or saddle nose. For lower respiratory tract, he can mention regarding pulmonary nodules and cavitation. You read about cavity with TB, it will be single cavity. Here he will talk about multiple pulmonary nodules and cavitation that is happening. And then kidney involvement would be in the form of RPGN, which will result in that hematuria manifestation. So vasculitis of the three with RPGN feature is what I have described for GPA. For eGPA, the word eosinophilia and asthma association will make your life relatively much more easier. Along with this, nerve involvement is there, mononeuritis multiplex that they love to ask. And now we come to microscopic polyangiitis, for which why this question will come is because he will give you the name of this antibody in the description. He might begin by saying patient had pulmonary hemorrhage, person had a hemoptysis episode, kidney involvement in the form of hematuria. So initially you might be thinking it can be good pasture also, but in good pasture you don't have a p-NK antibody, you have an anti-basement membrane antibody, and then he will say that the biopsy shows what I've highlighted here, fibrinoid necrosis. This is like the only one in the vasculitis component that I mentioned at the moment where the word fibrinoid necrosis is coming. In all others, it is granulomatous vasculitis, but this is fibrinoid necrosis which is to be remembered. So the data is like this. Let's do this again. Granulomatosis with polyangiitis. There is a vasculitis of the URT, so sinusitis, epistaxis, or saddle nose with lung involvement, pulmonary nodules with hemoptysis, and RPGN, the kidney involvement. If it's gonna be with asthma and peripheral blood eosinophilia, mononeuritis multiplex, Church-Strauss. If it is p-NK with that hematuria hemoptysis, okay, but p-NK is not with good pasture, and then he will mention the vasculitis finding of fibrinoid necrosis for MPA. For Kawasaki disease, guys, I'm very sure the pediatrics guy has spoken about it. The important aspect is lifelong aspirin is recommended if large coronary artery aneurysms are detected. That was an FMG exam. They gave a coronary angiogram of this patient. The description was this child is having fever for 5 days. And then he mentioned regarding the strawberry tongue. He also mentioned himself that the patient is having a unilateral cervical lymphadenopathy. You can notice this unilateral lymphadenopathy. And there is peeling of the skin. In fact, like since the data is given, so I'll just mark it there only. The point to be remembered is that you don't get a bilateral, but you get a unilateral lymphadenopathy in Kawasaki disease. Well, how to remember these manifestations? One is that mnemonic cream, etc. that they teach you. But I would like to make it simpler because those mnemonics would be difficult. Any mnemonic that goes more than 3 is difficult to remember. So I think the easier one to remember is what I say, that is MCL, mucocutaneous lymph node syndrome. He will begin by saying a child 5 years of age, like 4-5 years of age, 4-year-old child is brought with fever for 5 days. And when you are examining the child, you are noticing crash. Crash would stand for conjunctivitis, red eye. There's a rash which looks like initially like a faint rash on the trunk. So you thought maybe it could be a viral exanthema. There is a unilateral adenopathy, that is a cervical lymph node enlargement. There is a strawberry tongue, and then there is a hand and a feet desquamation. So crash is 5 alphabets. If you can remember, okay, I'm giving you a simpler version. Mucocutaneous lymph node syndrome. Muco would mean that there would be eye involvement, that is conjunctivitis. And muco would mean that there would be a tongue involvement, that is strawberry tongue. Muco is like the conjunctiva is red eye, and the tongue, that is like strawberry tongue. The cutaneous manifestation is the desquamation of the skin that I'm saying. The skin peeling of the skin of the palms and the soles would be present. That is the cutaneous. And the lymph node is the unilateral cervical lymphadenopathy. The combination of the 3 manifestations, muco, desquamation, and unilateral cervical MCL, makes it easier for you to comprehend Kawasaki. And in fact, in these patients in future, there would be a MI. If he says ECG findings of MI, I'll just write that peculiar statement. If you ever read a question that says there are ECG findings of MI, ECG findings of myocardial infarction in a 4-5-year-old child, then the first thing that you need to think of is the topic of interest, that is Kawasaki disease, because this disease initially starts with crash or MCL, but then progresses to cause myocardial infarction because there is a coronary artery vasculitis. Therefore, for the acute event, you will obviously give intravenous immunoglobulins. You will not be giving steroids in this condition. It is intravenous immunoglobulins which are to be given. And then along with this, we need to give aspirin. Whether the aspirin should be given for lifelong basis or for short duration. If the aneurysm is small and it regresses by itself in 6 weeks, then we will give like steroids for 6 weeks. But if the aneurysm is as big as this, then it will not resolve. So that was mentioned in FMG exam, that the child has developed a large coronary artery aneurysm. What would you recommend? Your answer would be that it is a lifelong aspirin to be given for these patients. For henox-choline purpura, the keywords would be palpable purpura, that will be on the buttocks and the back of the thigh. In fact, platelet count is always normal in this condition, so it is also called as non-thrombocytopenic purpura. I mean, henox-choline purpura is asked because this condition does not have any, normally like platelet counts become less for purpura to occur, but in this condition it is vasculitis, that is immunoglobulin A mediated damage which is present here. It is IgA mediated vasculitis which is contributing to rupture of these blood vessels in the skin. These blood vessels have become fragile. When the patient was sleeping in supine position, these blood vessels got ruptured. Similarly, the blood vessels of the GI tract can rupture, so they can be abdominal pain, hematochezia, and even an intussusception with henox-choline purpura. The bleeding, the vasculitis can affect the joints, so they can be arthralgia, and even kidney involvement can occur. Here I want to say that henox-choline purpura is a cousin of IgA nephropathy. Lot of cases may not have a kidney involvement, but if kidney involvement is occurred, then hematuria will also be given. Most cases that have come in the previous year have mentioned 3 features in a child, that is a triad of purpura, which is written as extensor purpura. Right in the beginning when I started the topic, I said extensor purpura word given, palpable purpura, and especially if I add the word extensor, or if he may not write the word extensor, the photo was given. That photo will identify that this is henox-choline purpura with bleeding in the GI tract along with arthralgia. And in this condition, C3 levels are normal. That's an important point to be remembered. Just like you know, C3 is normal in nephrotic, it is normal in henox-choline purpura. The treatment is steroids. Steroids are given for only renal involvement and the GI involvement with bleeding. Otherwise, like it is conservative management that is done. Like if it's a purpura, it will resolve by itself only, no? But only for the renal involvement, if there's a hematuria or if there is a GI bleed, that we give steroids for management of this patient. Then I would like to show a condition which the pathologist would have showed to you, that is non-caseating granulomas and the skin manifestation which is called as lupus pernio. In lupus pernio, the lesion would be looking just identical to what you get in SLE, but then you can notice a stark contrast that like in normal, there's a normal area in between, no, like there's no butterfly configuration present. This would be a purplish red discoloration over the nose and over the cheeks of the patient. The condition has non-caseating granulomas with asteroid bodies which are pink and the Schaumann bodies which are blue in color, basophilic. This condition, non-caseating granulomas, produce vitamin D because they contain an enzyme by the name of 1-alpha hydroxylase. Because vitamin D will be produced, that is why the condition will be having hypercalcemia. I will give prednisolone, then the granulomas will also resolve and the hypercalcemia will also resolve. So that is why the question says, which of the following condition is having steroid responsive hypercalcemia? The answer is sarcoidosis. Remember, the granulomas contain this enzyme by the name of 1-alpha hydroxylase. As a result of this, in this patient, vitamin D production, vitamin D3 production in the body is in excess or normal, and when you have excess of vitamin D, it will drive up the calcium in the body. I said asteroid bodies are pink in color, eosinophilic, and the Schaumann bodies are gonna be bluish in color, that is basophilic. Let me just highlight this there also. I mean, in pathology slide, if he wants to show you, yeah, basophilic calcium deposits, asteroid bodies, but the main is non-caseating granulomas. Overall, the most common organ involved in these patients happens to be the lung. Overall, the most common organ involved in these patients is the lung, and this would be having non-caseating granulomas involving hilar lymphadenopathy. The clinical manifestation will always begin by saying young female, and he will say she is having shortness of breath, and then he will say chest x-ray of the patient shows presence of bilateral hilar lymphadenopathy. I'll show you the enlarged lymph nodes also in like a couple of minutes from now, but bilateral hilar lymphadenopathy, young female, that's the commonest presentation. The eye involvement is by default anterior uveitis only in rheumatoid arthritis, as I told you. Only in rheumatoid arthritis, as I told you, it was keratoconjunctivitis sicca. The cranial nerve which is involved here is facial nerve bilaterally most of the time because parotitis can happen. So most common cranial nerve involved in sarcoidosis is facial nerve, just like you know it for Guillain-Barré syndrome. Then a peculiarity is CD4 CD8 ratio. This CD4 CD8 ratio is not in the blood, not in the blood. It is in the bronchoalveolar lavage. Here the ratio will be more than 3.5 is to 1, not 2 is to 1 like you read in AIDS. It is CD4 CD8 ratio more than 3.5 is to 1, but it is in the bronchoalveolar lavage of this patient that this finding would be present. Then you read about a variant called as Lofgren syndrome, where you would be having bilateral lymphadenopathy with arthritis and erythema nodosum. So it's a triad to be remembered. Lofgren syndrome shows a very good prognosis. The disease shows a self-resolution within approximately 2 years. The findings are arthritis, EN, erythema nodosum. That would be like purplish nodules on the shin of the patient, and then bilateral hilar lymphadenopathy. Then there's a Garland sign that can be seen in this patient where you get two findings on the right, one on the left. This Garland is also called as 1, 2, 3. This 1, 2, 3 basically means there would be two findings on the hilar and one is that finding would be on the left. So that's what they want to hear. Which finding is peculiar is the right paratracheal group of lymph nodes. Right and left hilar are there. Right hilar and left hilar are there, like left hilar, right hilar feature is there. The additional finding is the right paratracheal group of lymph node that could be present, that is called as Garland sign. Then there's a like a CT finding called as Galaxy sign, but I'm not getting into Galaxy because the radiologist will talk about it. But I said right and left hilar and a right paratracheal. Now in FMG exam, shockingly, he gave X-ray and he said, tell me the stage. Yes, guys. If you get only lymph nodes, if only lymphadenopathy is present, then I will say that the person is having stage 1. But if I get lymphadenopathy plus along with this, like you can see the lymph nodes and you can see even the parenchymal involvement happening, then I will say it is stage 2. So imagine only lymph node stage 1, lymph node plus lung involvement, then it is stage 2. If you're having only lung involvement, only infiltrates present in the lung, then it is stage 3. And if you get pulmonary fibrosis occurring, then pulmonary fibrosis means lungs will become relatively smaller. And you can see this lot of white opacities. I mean, extensive white opacities in both the lungs. The lung is shrunken in size. It is stage 4. So for sarcoidosis, mostly the question would be on stage 1 and stage 2. Let me just highlight this here. Why am I calling it 1? I mean, by algorithm, we call it 1 because this is where only lymph nodes are allowed. But if you get a combination of lymph nodes with I think this was the kind of X-ray that came in the paper, then it is stage 2 in sarcoidosis. If it's only lung involvement, then I'll say 3. That you can see even likha bhi hua hai. And then exclusively like fibrosis, if it is described, extensive fibrosis, lung parenchyma becoming smaller, then it would be 4 in the patient. So like the disease progression is what is occurring. Let's do a question here quickly, though I've highlighted the answer by default. Like the question was having that finding a non-caseating granulomas. The question mentioned pet cats. So a lot of guys read pet cats and answered it as stellate granuloma. Man, stellate granuloma is gonna be like this, no? So this is not a stellate granuloma anyway. And then epithelioid macrophages with central suppuration. That is a feature of TB. Now, here you don't see the suppuration in the middle. It is like a clear center that is, I mean, it's a center which is not exhibiting any suppuration. That's what I want to say. A lot of cellular infiltrate present. And necrotizing lymphadenitis. This is a feature of Kikuchi disease. And again, we'll be showing necrosis, no necrosis seen. So the answer here is B, lymphocytic alveolitis, that you can do on BAL. Na? When you do a BAL, there was CD4 CD8 ratio increase. So that same thing, that BAL, why I showed you this MCQ was to sensitize you to the fact that BAL lymphocytosis, bronchoalveolar lavage lymphocytosis, was not in the options, and like what you had to pick up was the word lymphocytic alveolitis. So these are a couple of technical details, guys, that I want you to remember for this important topic of rheumatology. And yes, in the end, I will say the routine thing, but that is important to you to be reminded of. Keep hammering, guys, and keep working like this, and you will sail on to the other side. Believe me, this is a highly condensed data, but this is having a lot of high yield information. So don't go by volume, go by like the core aspects of questions that you'll be able to solve on the basis of this. Thank you so much for hearing, and see you on the other side.